Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
Okay, good morning and welcome to Perf Web 30. Can you believe we've done 30 of these already? It's been more than 30 actually, because sometimes some are multiple days. But anyway, today's program is supported by LivaNova and Siemens Diagnostics. We really want to thank them for their support. Before I get started with the introductions I would like to ask all of you to do us a huge favor. If you are watching us on YouTube, Facebook, Twitter, or LinkedIn, please do one of the following. Like, share, follow, or comment. Also, for you YouTubers, please give us a thumbs up, subscribe, and click the bell icon for notifications of upcoming events. So, of course, the teleprompter is not scrolling, so be patient with me. Also, would you please go to perfusioneducation.com and leave a testimonial. You'll see it pop up here how you do that. It would be greatly appreciated. If you would like to be on our program as a presenter and join our robust resident faculty, please just send us an email at contact@perfusioneducation.com. Just last month, as you know, we introduced you to Dominic Capoletti, CCP, and he gave an excellent presentation on VADS. He also did a great job, along with Roger DeLong and Dr. Keshin Mathura, on the panel discussions. We also will be using Slido today. So go to, and doing some online polling and all that kind of stuff that we do. So go to slido.com, and where you see the little hashtag, type in PerfWeb30. Okay, and of course you can call in and be live on the air when you see this number and icon on the screen. That means the phone lines are in fact open. All right, so wait till you see that icon. And now let's get on to the introduction. So I'm going to go back to my chair over here. I was going to run around the table just to have some fun like Jimmy Fallon. I always wanted to be Jimmy. I always wanted to be an actor. It's really what I always wanted to be.
Then you have to do a little dance.
Yeah, I'm not going to do the dance. Okay, we're not doing the dance. All right, so now I need to get the introductions. Nobody got my computer going, as you know, so sorry for the minor delay, everybody. Just be patient with me just for a second. And we will pull those up. Okay. Oh, and you gave me yours. What did I do with it? I wrote it, and I have it somewhere. Okay, well, you're going to have to help me with yours, okay? So let's do this. So first up today, giving a lecture on ECMO for pulmonary hypertension is someone who has really become a friend of the program and a friend of mine as well. So Dr. Samir, once again, it's wonderful to see you this morning, and thank you so much for coming out here. But he is the founder and CEO of HS Consulting for Telehealth and the assistant professor of cardiovascular anesthesiology and critical care with the Weill Cornell Medical College and at the DeBakey Heart and Vascular Center, Houston Methodist Hospital. He's established and highly skilled physician with over 33 years of experience in critical care and intensive care medicine. He is involved in cardiovascular medicine, anesthesiology, emergency medicine, perioperative surgery, including transplants. In fact, you were at one time in the leadership of the transplant program, of course, over at Methodist. I don't know if are you still doing that?
I'm in transplant quality right now.
Transplant quality,
the
that's
quality
right.
aspect of it.
Right. He is licensed to practice medicine in 5 states, and is an esteemed fellow of Cardiac Renal Society and the American College of Chest Physicians. He's active in Extracorporeal Life Support Organization, ELSA, which we all, of course, know, and is the esteemed fellow of, and he is also the Society of Anesthesiology, Society of Critical Care Medicine, the SCCM, Society of Circulatory Support in Severe Septic Shock. Dr. Samir is published in the areas of mechanical circulatory support in severe septic shock patients, or severe shock patients rather, ECMO, severe sepsis, perioperative LVAD. In fact, you're going to love that device. I didn't even show it to you, did I? The sublingual. You've seen it, Dr. Zubieta. In fact, you've used it before. So anyway, I can go on and on and on, but Dr. Samir's passions right now are ECMO and ECMO monitoring. In fact, he's going to be talking about that today. And the thing about the ECMO monitoring is that he is very big in telemedicine. And in telemedicine, they're able to now monitor intensive care patients. In fact, that's what you do as a tele-ICU intensivist.
Absolutely.
And so we'll be interested to hear more about that. Now, to my right, immediately to my right, happens to be Sharon Kroslowitz. Sharon is a old dear friend of ours. We've known each other now for what, at least 12 years, 10, 12 years, about? And she gave me her bio yesterday. Let me see how much of it I remember. Okay. You started out with an associate's out of SUNY, State University of New York, and or SUNY, yeah, I say SUNY, yeah, that's right. And in respiratory therapy, you went on to perfusion school at the University of
Albert Einstein.
Albert Einstein, that's right, Medical College, that's right. You completed that in 81 or something. 91. Oh, 91, yeah, I forgot. I was I don't want to do that. Okay, and then you also worked, I don't remember all the places you've been. I can't remember the bio exactly, but to summarize your career, you have done adults, you've done pediatrics, you've done neonates as far as heart surgery and ECMO is concerned. You eventually moved down here to Houston and worked at Memorial Hermann TMC for about 13 years, right? And there you did mostly adult cardiac surgery, but you did pediatric, neonatal, and adult ECMO. And now for the past several years, you've worked with us here in the Northeast Houston, or Northwest, I guess would be the North Houston area, really, doing mostly private practice, adult cases, and adult ECMO. And we love having you. So how did I know that was a tough summarizing of your career, but I've done the best I could do.
Good job.
And then to Dr. Samir's right is Dr. Zubieta. Dr. Zubieta is an MD and a master's in public health, graduated from the Universidad Centro Occidental in Venezuela. Man, you come from a tough area. Tough area. Venezuela is a tough area. In May of 1995, Dr. Zubieta received his MPH from Morehouse School of Medicine in Atlanta, Georgia in 1999, postgraduate fellowship at Cooper University Medical Center in Camden, New Jersey, and Centers for Disease Control and Prevention, the CDC in Atlanta, residency and internship at Mercy Catholic Medical Center in Darby, Pennsylvania. Man, you've been a lot of places that I've been too. I know all these places. I was born in Philly. Dr. Zubieta has practiced as an attending intensivist at several institutions, including St. Joseph's Medical Center in Houston, Integris Baptist Medical Center, Memorial Hermann Northeast and Southwest, Valley Baptist Medical Center, Freeman Baptist Medical Center in Memphis or here in Houston?
Freeman is
No, Baptist Medical Center. Valley Baptist.
Oh, Valley Baptist is in the valley.
Oh,
here
that's right, in the valley.
Texas.
That's right. It's down by Harlingen and those areas down there. That's right. Freeman Hospital in Joplin, Missouri. I almost took a job in, not Joplin, but in, I can't remember the name of the town now, small little town in Missouri. Christus St. Michael's in Texarkana. Scott and White Healthcare, VA Healthcare System, UPMC. That's a big place. Memorial Hermann Northeast and the Woodlands, where I know you from. Dr. Zubieta was assistant professor at Texas A&M School of Medicine and University of Pittsburgh Medical Center. Dr. Zubieta also held the title of Chief of QA and Education at Centers for Disease Control and Prevention, the CDC, and was the hospital coordinator of Venezuela's Ministry of Health Rural Physician Primary Care Plus. Dr. Zubieta is or has been a member of the Neurocritical Care Society, a fellow, American College of Chest Physicians, and the Society of Critical Care Medicine, as we know it as the SCCM. And then we have Becky Bolkovac. Okay, finally I can pronounce her name properly. Okay, so Becky, you're gonna have to help me since I don't have your introduction because nobody put it on the web where I read it from. So I'm gonna ask you to do me a huge favor. Becky now works with us here at HET. She's joined our team. She's at Memorial Southeast. She's about a 12-year perfusionist. I know she's worked in Alabama and several different things, but Becky, I'm going to ask you, would you please tell our audience where you're from, where you trained, when you graduated, and what your passions in life are?
Oh, sure. I went to school at UPMC, actually, Shadyside, and graduated in 2007, took a job in Virginia, so I'm from like the Newport News area in Danville, and then I moved to Alabama, and now I'm here in Texas.
Are you loving it?
I love Texas.
Is it? Okay, no, that wasn't where I was going with that. You work with us? Are you loving that?
I love HET.
Oh,
and
good.
Texas.
Okay, I finally got it. How about you? How about you? And you guys, from the clinician's perspective, when we come in to help you guys and facilitate, would you not say we were the best?
Of course.
You're amazing. Nobody is like you. Oh my God. I wake up
good.
every morning thinking, who's like Joe?
Exactly. Very, very, very few. Okay, so we're going to just move straight forward with the first presentation, which is going to be Dr. Samir, and it is going to be on extracorporeal life support as a bridge for pulmonary hypertension. So, Dr. Samir, with all of this said, please take her away.
Okay, this presentation was inspired by a paper that I read, and I don't read that much, but I was very impressed by this paper. And I'm a little biased. It came out of New York, my hometown, from a small hospital there, Columbia University. Dr. Rosenzweig, and they have an amazing experience. I mean, Journal Heart and Lung Transplantation was published in it, and it's a.
Oh, you need the controller? This here. I'm sorry. Okay. You can use the controller. You have to make sure that you switch your slides. If you're going to use this to read, and you switch slides here, you have to make sure you switch your slides up there.
Yeah, I know, but I'm working a different way.
Okay.
Yeah.
So sorry.
No problem.
I only did what I was told.
No, I know, sir, I know. So, again, so this is a combined paper between Presbyterian and, Tennessee, Vanderbilt, two small hospitals, I would say. Dr. Rosenzweig is amazing. I met her before, and it's an amazing experience, Now, it's a scary thing for me, and you guys feel to jump in anytime. Patient with pulmonary hypertension, severe pulmonary hypertension, is a very scary patient for me. They never come just a little sick. They come usually crashing and dying. And we're gonna talk about that a little. So this is something we need to focus on our work every day. And I like this quote. Apparently Socrates knows something, which we didn't know. That we need to focus our energy in doing something good, not fighting the past. That is a very important thing. And that's why I am a big proponent of telemedicine and tele-ICU and tele-ECMO, because we have to move to the future for better care for our patients. Pulmonary hypertension is a very, very, very bad disease. And unfortunately, there's no easy solutions for it. And any patients coming to you to see pulmonary hypertension, they're in bad shape. Do you agree or no?
Yes.
And there are multiple reasons they're in bad shape, and we'll go through that. Bad shape, and they're desaturating, and you're not sure how bad their heart is, and you're not sure what to do. And not every hospital, not in Houston, any other place, has nitric oxide and has ECMO and all of that. Do you have nitric oxide in the hospital?
I don't. We have Flolan. We use prostaglandins, but we don't have nitric oxide.
See, our surgeons will tell them Flolan as if you're cursing them.
Yeah, I know.
Because of the platelet dysfunction, they can't stand Flolan, and it's nothing pretty. So we use Flolan, but it's that we're lucky we have nitric oxide. But I love nitric oxide. I feel nitric oxide should be in the air, should be misting around. But you know the cost of nitric oxide, and unless you have a good contract, and it is what it is.
Well, I don't mean to interrupt, but since nitric oxide, and I hope you'll touch on it. How does, what would an infusion, maybe even a direct pulmonary artery infusion of sildenafil do in regards to, having an alternative to nitric oxide? Nitric oxide would be much better, but
the problem is those patients are on Voltaren and other drugs coming from the hospital, and they're coming crashing and burning, because there's something to tip them over the edge.
You need something that's going to be more immediate.
Exactly, and that's the problem. And and you're right, nitric oxide is not easy. You have to be intubated. You have to have the facility that has it. Not many facilities in Houston or the U.S. has nitric oxide.
I find that interesting, because it's not a hard thing to have.
It's a very expensive thing to have. That's the problem.
It's expensive, But it's expensive not because it's difficult to produce.
No. I mean, your body produces nitric oxide, you know, but what can I say? And so and the problem is that you have to look at, which is, I gave this lecture maybe a couple of months ago about the exit strategy. I'm a big believer, and I'm sure you agree. Don't put anybody on ECMO unless you have an exit strategy.
Yes.
You know? But the problem is, and I'm not trying to be sexist or anything, most of the patients with pulmonary hypertension severe, they're females, they're young, sometimes they're having a baby, and you're not going to hear say, well, let's see. I'm sure you had this situation. Let's ponder, should we put on ECMO or not? Let's see the situation. So you're really an extremist. Every time they come in, I feel like I'm pushed to the edge. You know what I'm saying? There's a problem. Pulmonary embolisms, I know there's something very bad and deadly. Chronic pulmonary hypertension is deadly. And now you're going to have to get the Rome. Is the exit strategy going to transplant all these people? And they're going to do a lung or a heart lung. And it's a whole other world, you know what I'm saying? And I hate to say this, most of these patients come into extremis because they're not compliant with their meds. And their non-compliance brings them into the hospital with failure and they come crashing. We call it the double doors crashing and burning. I've been in this situation with perfusionists, Joe.
Yes, sir.
Some of the perfusionists, you know, where they're sitting in the OR chatting, and when the door comes, the double doors open, and the patient's coming crashing and burning. And they're rolling the patient to the OR without even letting us know, because they know that this patient, one more minute in the ER or in the ICU is going to die. They've seen it before. And once you intubate this patient, they don't get better right away because you don't know what their heart is like. The heart could be failing. So you have to think right away, what are you going to do with them? So you put them on ECMO regular? I mean, so the strategy has to be in your mind. So there's no medical treatment except, unfortunately, transplant, or ECMO is just buying you some time. So we're going to talk a little controversy right now. So is going to be a bridge to transplant, or is just buying time? What are you going to buy time with? How are you going to buy time? So this is just a little paper I was talking about before. I wanted to talk about it first. And now here's the concept of ECLS. I was not really with that concept 100% till I talked to one of my friends, Dr. Ibrahim in Hamad in Qatar. And they have a very robust ECLS program. And I'll tell you something, I'm a big believer for ECLS. I wasn't before. I'll tell you, this is going to be a controversy. There's going to be a lot of people going to shoot me probably when I leave here. If you have a transplant program or a VAD program, you have to have a very robust ECLS program. You cannot expect your code team is going to take care of these situations. Your code team is, gets called for other situations. So their code team gets called to manage medical situations. But the nurses know if there's a VAD or a transplant that codes, they activate the ECLS program. And the ECLS program are in the hospital and available. That's a lot of cost for that. Because you have to have surgeons, perfusions, equipment ready, cardiologists, pulmonologists to take care of that situation. So we're just going to look a little at the paper, and from it, we're going to come with some opinions. So here's our treatment goals. These patients, what are we going to do with them? Are we going to just buying a bridge, get some IV like Volturi, some nitric oxide, temporary situation, support their RV temporarily? I'm a little biased, and Joe is going to beat me right now. I got the best bang for my buck. If we're going to put this patient on ECMO, initially you're going to go standard ECMO, but support the RV, put an oxygenator, and go standard ECMO. And if you're having differential hypoxemia, which we'll talk about later, you can do double cannulation strategy. Do you agree or no?
Yes, I do.
I mean, the
How
beginning
you do the double cannulation strategy
and don't jump ahead of me.
I'm not, but I think
jump ahead of me.
I'm trying not to.
Okay.
I'm trying to listen to you and them at the same time, but I'm picking up all that you're saying.
Okay. Don't make me call SEAL Team 6 right now.
See, that was my line. You're still on my line.
So, I mean, the question is, you're calling the ECLS a bridge to nowhere or a bridge to something? And what's your thoughts about that?
I think that the ECLS is very important. When we started working on putting the heart transplant and the VAD program at Scott and White, it's now called Baylor Scott and White.
Yes.
But at that time it was not Baylor. It was just plain Scott and White. my mentor, Dr. Gongora, who is in Alabama these days, the first part was just to make sure that we have all the pieces together and we were able to do the transport. And the next step was to build the ECLS program. And having the ECLS program in the house required, to have a great amount of people, well trained and ready to respond to the emergency.
I agree 100%. And I'll tell you, here's my little bias comes through. And that's where tele-ICU helps you a lot. So if you put let's say now in Memorial Hermann, you put an ECMO in one of the small Memorial Hermanns. I mean, you have to call it Central Memorial Hermann, make sure there's a bed available that you can be able to fly the patient out to. That's how tele-ICU can help coordinate all these hospitals together. Yeah, you're looking at an airport board, seeing your small hospitals and the main hospital, and seeing what's the availability to send something from the smaller hospital to the big hospital if needed. And that way, all these hospitals can do everything that they need to take care of these patients.
Yes, and I believe that now with these big systems like we have in Houston, where we have plenty of community hospitals and a big mothership, as I call it.
Yeah.
Well, the small community hospitals have something that the mothership doesn't have, which is beds. And the
Bingo.
mothership has something that the smaller hospitals have, which is the technical expertise and, maybe a little bit of technology that is not available in the community hospitals. And I have been working really hard to try to actually close the bridge and to build a relationship so we can have the best of both worlds. And the whole philosophy, well, at least my philosophy, is that it doesn't matter which door the patient goes through, the patient is going to receive the best possible care.
That's an amazing concept. That is an amazing concept.
Would I be interrupting you if I added to this conversation?
Please go ahead, sir.
Because I don't want to disrupt your flow.
No, we're very good. We're an open flow.
Well, with everything that you just said and with everything that you just said, us here on the panel, from our perspective, could not agree with both of you gentlemen anymore. Here's what the issue is, and I just went through this experience. I won't say where this occurred, but I think you know. We have a hospital that has the capability. They have two different ICUs. Most of the hospitals that we have in the community area has one ICU for everybody. In this case, there's two separate ICUs, and they're on two different floors and wings of the facility. When we put an ECMO in with the model that we have to be at the bedside 24/7, or at least within close proximity to the bedside. Everybody walks around a little bit and goes to the cafeteria a little bit and then back. And we have that kind of relationship depending on the staff, the nursing staff that we're working with. I know you're more hesitant to do that than I am, but we do, depending on our comfort level and how many of these we do, how stable the patient is. In this case, they wanted to keep the two patients in these two separate units and not move one to the primary, what I would call the primary unit, which would have necessitated not just me having to tie up 3 staff every single day, it would have required me doubling that to 6 staff every single day for something that should only require 3. Now, let's take that a step farther. As you were talking about ECLS, and how important timing is to survival. When you hit the emergency department and you want to put the patient on ECLS immediately, but you put the call out to everybody when you've made that decision, guess what you're going to be doing? Waiting. Why?
Because your perfusion's busy.
That's where the problem comes in. That's where training nurses, because there's so many more of them. This company, HET, that basically is who funds all of this, but the MediWeb, PerfWeb, what we're doing here is a separate company technically, but it's not. It doesn't make any money. Okay, this company makes no money. What we're trying to do is do something of value, but that's a separate point. The fact of the matter is there's not enough perfusionists to cover all of the possible ECMOs, and we're not always in any one hospital. You need to have, this company was built basically by training emergency room doctors how to set up and initiate ECMO, how to prime the ECMO circuit, built one that was, we called it doctor proof, no offense, I hope you won't take any, but easy, it's self-primed, put the cannulas in, hook it up. The perfusionist is on their way to make whatever, maybe adjustments, fine-tuned adjustments need to be made, but you can get the patient on ECMO right now without waiting for us. The fact is we need to train nurses. You want to have ECMOs in 3 different units in your hospital? Well, I don't care who you are, what company you are, how big you are, it doesn't make any difference. There are not enough of us. There's 4,000 perfusionists in all of the United States. There's 3.4 million nurses. It's a question of math. So that's my view.
So my answer to, and I agree with you 100%, and we've discussed that before. I think nurse ECMO specialists are very important, and I think going with the same model, like intensives are not available all over the place, and that's why tele-ICU has becoming a big concept. I think there's a space for tele-ECMO. I mean, you need to be what can you affect the patient change immediately for your bedside? I mean, you're gonna have a physician or a perfusionist monitoring a few patients and be in touch with the nurse.
Yes.
Bedside.
Yes.
And the nurse was specially trained to take care of ECMO patients.
Yes.
And the perfusionist are able to manage flows, FiO2, volume.
Right.
And if there's a surgical emergency, you still have to activate the surgical team.
Correct.
At the same time, from surgical emergency to OR door is going to be, whether it's tele-ECMO or on-site ECMO is going to be, in my opinion, the same.
Look, I agree with you 100%. Look, at the end of the day, if you have a catastrophic event occur, an unintended decannulation of the patient, the line gets yanked out. It doesn't matter if I'm standing there. If I'm standing there, and I'm a fairly experienced perfusionist, patient's not going to survive the event. If the oxygenator were to acutely thrombose and just completely clot off, and the patient is on VA ECMO and 100% dependent or even 80% dependent on the VA ECMO, that patient is not going to survive. I mean, those are just realities. So I really am unable, if you have a well-trained nursing staff who sees potential trends, and that can be done by monitoring and by recording and having people, contact when you start seeing a trend in the direction that you don't want things to be going, to come in and evaluate it. But when there's an acute problem that is essentially 100% cessation of flow for whatever reason, it doesn't matter whether 10 perfusionists are standing at the bedside at that moment, the outcome has been predetermined.
Well, I'm going to use the same concept of the tele-ICU. The doc says, patient's tamponadic, you need to take patient to the OR. The same, you have to activate the OR, get everybody in. So I feel it's the same timing. I feel there's no time lost. You have the expertise to make the diagnosis. The most important thing is to make the diagnosis of the problem, and then deal with it from there.
Yes.
Most problems happen because you're misdiagnosed or misinterpreting the data. That's what remember, like people said swans were killing people. Swans are not killing people. People are killing people. Misinterpretations of data is what kills people. So if you have experts like you behind the screen looking at the flows of oxygenation going down, and then there's a problem, you activate the surgical team. So time to take care of the patient, I think, is going to be, that's the most important. Diagnosing the data, making a decision, and then going with it.
Yeah, and I have agree with you in a sense that I have said perhaps we should have a special credential to actually read a swan, because there is nothing more dangerous than somebody with a swan whose doctor doesn't know what the numbers mean.
That's scary.
That is a problem, and
that's a very prevalent scary.
If you look at the trend when they say, okay, well, the swan is the evil thing. Well, that paper that was published, and everybody quotes about the swan. Well, they put the swan when there was nothing else that could have been done. Mm-hmm. And like the pulse oximeter that doesn't save lives, like an arterial line that doesn't save lives, The Swan is a monitoring
Cerebral
device,
oximetry.
and what it will save a life is what you do with the data that you are collecting,
Of course.
and the interventions that you are going to implement on that patient based on the data that you are receiving.
Yes, agreed.
I have to tell you, me and him are going to be a strong force right now. I like
Good.
that.
I like it. Is it going to be 2 against 1?
No, we'll see.
Well, this is 3 against 1. Okay? So let's put things in perspective. OR, internal medicine, pill pusher.
No, but
So I am the minority over
no,
here.
but you're talk about the Swan is like, I tell you, swans don't kill people. People kill people. So what I'm trying to say, misinterpretation of the data. If the perfusion is sitting bedside or the nurse bedside is not showing what's happening, but they have an experienced perfusion that can monitor a few patients at the same time from a command center who has a physician to back them up, and a board certified physician who is certified in ECMO to back them up, and has a good relationship with the surgical team. Like saves you all. He would make the phone calls. Doctor, I'm going to have to use my buddy's name. Dr. Bruckner, you need to get the patient to the OR right now.
Yes.
And that relationship is very important. Patient goes to the OR, whatever needs to be done gets done. So I don't feel and I have to tell you, if I was you sitting bedside and not getting my coffee, I'd have to be restrained. Somebody's going to have to restrain me. It's going to be a big problem. So, for me, I do think our expertise, all of us have to be used judiciously.
Yes.
So.
But the problem is the expertise. And this is where what your concept is where I think we're going to have to go, is because just because I train, let's say we start our, Sharon and Becky and we get our ECMO specialist, nurse ECMO specialist program going, and we teach all of these nurse ECMO specialists. And they go out to their respective hospitals and they're monitoring the ECMO. The one thing you cannot teach is experience.
Absolutely.
When I get a phone call and they tell me this, this, and this, I can conceptualize it in my mind because I've probably seen it half a dozen times or more. And so I know what to ask for, I know what to expect. That's where I think people like Dr. Zubieta, Dr. Samir, Sharon, Becky, myself, are so important to have that expertise readily available in a telemedicine type of program, to where the nurse sees something, feels something, calls, you get to see into the room, see the patient, see the monitors, see everything that's happening, and you can give them guidance on what may or may not need to be done. And it could be that they're 100% correct, but they feel like they have that support. And I think that's extremely important. And what the real value of this is you bring a high level of experience to many more places.
Absolutely. I cannot agree with you more, yeah.
Of course, I would have no doubt.
So going back, I'm sorry we diverged a little bit, but I like this.
I'm not going to say another word.
No, this is a great discussion. That's what it's all about. It's different opinions, you know what I'm saying? So now here, patient codes, and you and I have to discuss this. Is this a patient good candidate for ECLS? That's the big controversial way. Who is a good candidate, who's a bad candidate? I have to say, I'm very lucky. We have a very robust ethics committee. But at that time, when the patient is crashing and burning, there's not time to do a journal club. Our head of heart failure taught me that. And not a good time to have a journal club, so you believe in putting them on ECMO, then see later what you want to do? Do you agree with that or no? Put them on ECMO and then figure out the situation later.
Yes.
Yeah. And then if it needs to be turned off, if there's a decision to let the patient go, then I think we should be able to turn it off. I think the time is brain, time is heart. So pondering who I would, should we do it, should we not do it? No, just do it. And that's a controversial approach, but I'll tell you, I believe in that, because get it all in early, you're saving as many organs as you can, and then you have the luxury of time later. Temporize the situation, and then, then the later ethics committee meets, talk with the family when things cool down a little.
Yes, absolutely.
Yeah.
Mm-hmm. The problem is that many times, and I have no issue with what you're saying, I think what you're saying is 100% correct. Put the ECMO in, unless the patient comes in decapitated. Then I would not recommend it. But sometimes I've even seen those.
Is it contraindicated there?
I've seen those. Well, I've seen those put on ECMO too. but you get it in, but there is no protocol for an exit strategy. It is all put on the burden of the patient's family. And I think that is fundamentally wrong.
And I'll tell you, I recommend, I give credit to our heart failure team and lung transplant team. We have a very robust ethics program. Every patient, if they're electively going to get a VAD, they're going to see by ethics. And electively going to get a transplant, they're going to be seen by ethics. You need to have ethics and you know, meet them with the family, discuss goals of therapy, be realistic, be honest. You're going to take a VAD, you're never able to jump in the pool. You're going to be able to have a very guarded life.
But that means you have to, somebody, and I would not want to be in that very enviable position, but it requires that somebody or some group of people have to accept that they may say, we don't believe this patient is going to be a survivor, and I have been fooled myself before. Not very often, but it has happened to me where I have said, I don't think grandmom's gonna be, I think she's gonna be cooked before the turkey because it was close to Thanksgiving at the time. And grandmom walked out of the hospital and I was shocked. So that's the enviable position somebody has to be in, because you know you're going to withdraw care and you just do not 100% know. Now, we're pretty sure, sometimes, like we're almost positive, but there's curveballs. And I think that's the ethical dilemma that we all have to suffer, you guys more than us, but suffer with internally. And I would not want to be in that position.
I mean, that's why, I'll tell you, that's why you have to be very honest with the family, extremely honest. And we lack that sometimes. I've never had a family complain that we're too honest with them. Have you had that ever?
No.
Family loves to be honesty.
No, they get angry because you're not transparent with them. They get mad because they think you're hiding something from them.
Yeah, be very honest. Tell them what's happening. Tell them where we're going, where you think we're going, based on results and tests. And you have to use your experience. I mean, we have limitations, but we have to use our experience. And if you have organ breakdown and you have rising lactates,
yes,
things like that. All of us know physiological indicators. We give them the best data we have, and we try to make a decision.
Yep.
And it's not just about surviving. I mean, for me, it's about not waking up. It's about getting out of the hospital, having a meaningful life.
Yes, of course.
Meaningful life is a very important situation.
Yes, that's far more important than just survival.
I mean, you walk in let's go to the mall and ask people, do you want to be on a vent for the rest of your life, or you want to be able to walk around? We'll see what they say.
Well, no, that's not a good question. Do you want to be on a vent for the rest of your life, or do you want to be dead? I mean, you have to you can't say or walk around. That's kind of to
be honest with you, I disagree with you. If somebody tells me, Henny, you're gonna be on a vent and that's for the rest of your life, what's your choice? I would say it's okay. It's okay. My time is done.
Yes.
Let me go. I mean, there's nothing wrong with that.
Me too. Yeah. I feel the same way.
And we joke about it a lot, but I'll tell you, I have in my mind my advanced directive criteria that if I get to it, I don't want anything else. And I tell that to my wife, and she gets mad. But it's reality from what we see. Is like all of us have certain lines we don't want to cross. I mean, for me, dialysis for the rest of my life, it's not quality that I want.
I don't want that.
And other people that's okay with, and so it goes to what your beliefs are, and that ethics committee helps with that. And I think really you have a robust, when you have an amazing group of ethics people, they really help a lot. And you let them talk to the patients and just be very honest. Your job as a clinician is to provide the best data you can provide. Let the family and ethics decide together. I think that's my own personal feeling. Do you agree?
Yes, I agree with you.
So I'll tell you, with that said, some of my friends from Australia, and I'm not sure you know about this, Australia, they do not put peripheral ECMO. The ECMO team is like a zip the chest ECMO team. They want to put the body on ECMO, they will zip the chest open and central cannulation. So this is Australia. We think like we're doing crazy things. They are doing like crazier things than we are. So I have to say, when I see that, myself, see, we're not that crazy. I know we're not that crazy. So the physiological differences are very important. If you have a dead liver or a dead kidney on ECMO, you know that the outcome is not that good. I say, and I use a couple of numbers. If you have a lactate above 20 and total belly above 20, on ECMO, there's going to be a very big problem in the future. You know, these are two numbers that are solid indicators that's going to be, outcome is not going to be survivable. SCCM made it very easy. Two same numbers, 20, 20. The outcome is going to be very bad. So, now, ideal configuration of ECMO, I know me and Joe are going to fight hard at the end of the talk about that. Optimal timing is right away.
Wait, go back. What is the optimal timing? Okay, good.
That is right away. Should you intubate first? Should you put in, you know, that's the strategy they followed in this paper. They intubate and put an ECMO right away. Okay, at the same time. You should not. There's nothing to wait for. Just go ahead and do it. You know, those pulmonary hypertension patients are bad. It's a bad disease. So. Here, go ahead. So you see the goal is like early cannulation. You know, you don't want any end organ damage. I mean, when your liver is failing, kidney is failing, it's over. Your heart is cooked, it's over. And that's why should you ponder. Now I'm gonna let Joe here weigh in. What's your favorite circuit in all these circuits for ECLS?
For ECLS, my own.
Remember, for ECLS.
Yes, for ECLS,
Yeah.
I agree. In the emergency room you're talking about. Or are you talking about,
in the
are you talking in the emergency room or are you talking about on the street?
On the floor.
On the floor, my own system. Need none of these. I do not like any of these pre-packaged systems.
But you have to remember, the world, you're going to have to go with a pre-packaged system that kind of. Okay.
I mean, so you're telling me that my only choice is one of these three?
Because not everybody has Joe. We wish everybody has Joe.
Any of them. I
would say cardio help. It's easy, compact, and it has a long battery life. You know what I'm saying?
Sure. I mean, if that's what you want me to say, I'll say it. I mean,
no, I'm not asking you to say it.
Cardio help.
I'm not forcing you, you know.
No, no. But put that gun away.
So, so you know, the idea is have something easy to put in, compact, transfer, ready to transfer the patient out. Now we're going to ask
Can I ask two perfusionists? Who,
Absolutely.
Since we're the ones who have to run the thing, okay? You get to say, put this in, that's what I want, but we're the ones who actually have to do it. So of these systems, or our own, which would you choose?
Our own.
Of these systems, which would you choose?
I'm going to interject here for 1 second. We're putting the cannulas in. We're putting the cannulas in. And you just choose it. The system really does not matter to the physician. It doesn't matter to the physicians. The systems, no.
What's important is you use what the perfusionist is comfortable with.
Exactly.
Of course.
I mean, they all work, but it boils down to what is perfusion comfortable with. And the system that we use, it's not considered transport, but we've transported with it.
Yeah, we transport with it all the time.
And it's small, and we can put it together.
But from intra-hospital transport, it's very simple.
Can you elaborate on the system you're using? You have to tell everybody. They don't know what system you're using. So now I'm going to pick on you now. You're on the hot seat.
Oh, Lord.
See, you had to say that now, so you can thank Joe.
We use the Sorin system.
Well, it's Levanova. It's their iteration. They call it a trolley. Of course, they're not allowed to call it an ECMO. They call it the technical term they use is SPC, SCPC. But it's on a trolley. It's very movable. You've seen our system, Dr. Zubieta. You're familiar with it. And it just rolls around. You can roll it with the bed. You can adjust the line lengths very easily so that if you have a patient you want to put in the CT scanner, the whole ECMO doesn't have to go with them when you have one of these other little systems. And you can still manage the patient's support system outside of that field, but yet you can also have it right on the bed with them were you to take them via ambulance. Now, for air transport, no. You're going to do air transport, you want one of these other systems. However, when you're doing air transport and you're sending your patient from a community to a tertiary care facility or a quaternary care facility, then they are going to come get the patient with their own transport system. So you really don't need to have one.
Actually, to be honest with you, I don't agree there. All the ECMOs that we've gotten them ECMO'd already.
I'm sorry?
All the ECMOs that we have gotten them, the ECMO system was there already. They were already.
No, we have but they'll switch them. The helicopter will have their own ECMO system. And what they'll do is they'll come to the community hospital, convert the patient from your ECMO system to theirs. Because let's just hypothetically say I had one of these very expensive systems. Well, I'm not about to send that system away to another hospital with the patient. I need that for another patient, and they're extremely expensive, and you don't want it to get lost. So the transport services have their own approved transport ECMO circuits, like the Cardio Help or something like that, and small, compact, fits in the helicopter much more easily, a lot less weight. So there's things that make that system good. It's just that for the intra-hospital system, it's, I think, overpriced, much more complicated, and in many ways, in my view, less versatile in being able to do other things with the system. It has more limitations than a hybrid system, if you will.
One thing I will tell you, I feel like a big system, like the biggest giant system, they should agree on one system they're going to use, like Methodist, Memorial Hermann, something like that. One system they're going to use, because once they put it in, it's going to the same Memorial Hermann or Methodist.
Well, it may be, but I can tell you right now, the community hospitals, you have the hub, as you call the mothership, I think, Dr. Zubieta, you used, and then you have all of these satellite hospitals. Well, yes, they are all part of the same system, but they also all have their own budgets, and they don't want to lose money in technology. So it does work from a technical and what is the word I'm trying to use, where you have these expertise that is shared easily, expertise that's shared readily across that hub spoke design, but not necessarily all of the things that it takes, the widgets to run a robust program.
Okay, one other question I ask about your system. Heparin, how much heparin are you on? I mean, how much PTT, what's your PTT goal?
It depends on whether it's VA or VV and at what point in the procedure we are in. So if it's a VV, I go with 1.5 times the baseline for the APTT. So a patient that has a PTT of 30 as their baseline, so then we would do 1.5, that's a 45.
Okay, you don't think you should adjust it to flow, not to...
Yes, I do. I think if you have a low flow state, you need... Sure, but that's where expertise comes in. If you're trying, for example, on VV ECMO, when you're trying to wean a VV ECMO, there is no reason to turn the flow down. If you just reduce the amount of ventilatory support you're giving them through the artificial lung. But if you're VA, you have to turn the flow down. That's the only way you can do it. And in those cases, I always remind people, and of course our team is skilled in this, to say, hey, we need to go temporarily up on the heparin because there'll be a longer transit time through this artificial surface and increased thrombogenicity because of that.
I mean, I just want to remind people that you do not need to use 40,000 units of heparin. Some people do that.
No, of course
I know,
not.
but I'm not talking about, not everybody's you guys, okay?
Yeah.
Remember,
I mean, we're
talking to the world.
Yes.
Yeah.
But you have to assure appropriate anticoagulation at the same time. So 40,000 units of heparin as a single dose is a lot. We do heart surgery with it all the time.
Exactly.
It does have, a somewhat definitive half-life. You can reverse some of it if you really had to, though I don't recommend it when you're on ECLS. However, and with that said, the risk of over-heparinization as a single event is far less than the risk of under-heparinization in that same circumstance. So give too little or give too much, in that circumstance, I would say giving too much is the probably safer thing to do. Neither's great, but one is definitely worse, because once you clot your system off, once you develop thrombus in it, there's no getting it out. You have to now change that circuit, so you've compounded your risk.
For me, I have to tell you, 5,000 is great of heparin, and then you can run a drip if you want,
Yeah, 10,000 would be my comfort zone.
That's just a little weak. 5,000 is good. That's weak. That's really weak. 5,000 is more than enough.
Once again, you're not the one that has to change the circuit. You only get to stand there and yell at everybody for taking too long to change the circuit.
We have to compensate for the patients hosing blood out of their groins.
It all just depends on where. That's right. But you can have stitches there's suture for that. And there's suture, Avitine. There's all kinds of things. There's that stuff made from potatoes that you can pour in there.
Yes, the powder, yeah.
Yeah, the powder, sure. Yeah.
So I mean, I have to say, I do agree with the 40 to 60. You know, and then there's people which might be a little crazy. 500 units an hour rate. Do you believe in that?
100 units an hour?
500 units.
500? I mean, do I believe that that's where the level should always be? What's
Like
your question?
they're giving a bolus and then 500 an hour straight. No titration.
But every
No,
patient
that
is
doesn't make
different.
sense.
Everyone reacts differently.
Yes.
You have to
You have to-
adjust it to
right.
your patient's needs.
You have to
and
measure
your
the
flow
labs,
and-
right?
Well, the reason they use that is so nobody keeps it, like they have no clinical pharmacist that goes around.
You have to start somewhere.
Yeah.
And so I would say you give a bolus, depending on how much of a bolus you give, would depend on whether you should start the drip or not. If you're only going to give 5,000, I would start the drip immediately. But where I think everybody makes a mistake is they will titrate the drip depending on where the PTT ends up falling, whereas I think that you get some steady state, and then as you see small variations in your APTT, you give small boluses and see if that resets the baseline. Because a lot of times you turn it down, it's a while before you see, oop, went too far, then you're turning it back up and oops, we've gone too far. So I think small boluses with a set rate is an easier way to maintain a tighter margin within your APTT.
And check 83 levels.
Of course, if you can. But
You
know.
should be able to. If
Yeah.
you're doing ECMO, you should be checking 83.
Yeah, we'll put the notification up that it's on there. We can check it later. They can go ahead and log into Slido. Oh, you need me to? Oh, so sorry. He told me to. Okay, go ahead.
It's not my fault, man.
We'll
It's
skip the break.
Not my fault.
We're going to skip the break. Don't worry.
Anyway, this is the study. They looked at different patients and their scores. And I mean, since we are a little behind, just going to go a little more. Now, this is the different groups. And every one of those diseases, that wheel is a nasty disease. Sarcoid, isolated pH, patient with, thromboembolic polymyositis. Every connective tissue disorder with pulmonary hypertension is a huge problem. Do you agree?
Yes.
Those diseases have bad hearts, bad lungs. Every sarcoid, I believe, has a very bad heart. I'm very scared of sarcoid patients putting them to sleep, the bradycardias and arrhythmias and all that.
Yes.
And so, every one of these connective tissue disorders is a big, big deal. Scleroderma, another very bad disease. To get access, now scleroderma access can be very, very difficult. The surgeons have to dig really hard. Skin is very tough. Biggest part of scleroderma is the skin is very thick. So I'll tell you, these are of experience, and I do worry about when they start digging and then dilating and all that. They have to dilate more than usual, and then bleeding starts hosing out.
I'm surprised ARDS is such a small slice of that.
Yeah, to be honest with you, there's not. I think it's late ARDS. You have pulmonary hypertension. Do you agree?
Yes.
Yeah, it's late ARDS. I mean, the problem is these diseases, the pulmonary hypertension is building up from the beginning, long time,
Chronic.
long-term, chronic, exact. And some of them have very bad hearts, and so you are gonna have to listen for heart lung. Now, this is a big controversial statement I'm gonna make, and I'm sure somebody from both hospitals is gonna attack me on the way home. I think everybody who has pulmonary hypertension needs to be listed for heart lung. There's questions that pulmonary hypertension gets better out of a lung transplant alone. But are you willing to take that risk if you're going for transplant? If you're going to go for transplant, I believe you're going to have to go for heart lung if you have bad pulmonary hypertension.
I believe that. The right heart's going to be damaged.
Exactly. I mean, COPD, everybody has, remember, sleep apnea gives you pulmonary hypertension. All these things, there's a lot of things that give you pulmonary hypertension. But again, which ones are really bad, irreversible, you know what I'm saying? That you're going to crash from. Now here is like the changes in group. Now, I love nitric oxide. I think the time to start nitric is when you think about it, not to ponder it. So for me, when I start nitric in the OR, patient goes to sleep, gets intubated, they get nitric out right away. And then run it straight through, okay? And And if you're having a problem, put the patient on ECMO. And now I'm going to say this later when I put the cannulation and continue the nitric. Because you have to open the bridge between the right and the left, and you have to keep it open. And unless you're going to have a different cannulation strategy, that bridge has to stay open. Milrinone can maybe do a little pulmonary vasodilation, but there's a cost for milrinone, which is systemic hypotension. And now, if you're going to be going on ECMO and you're going to add systemic hypotension to your problem, why not continue with nitric oxide if you can? You can use a process that'll make people happy. You're using down nitric. When I start nitric, I go for the gold, 40 parts per million. And you get things going. Once things are calming down, you can wean down. But I tell you, you need to go, if you're going to open the bottle of nitric, go for the gold from the beginning. Because once you pop the bottle, the cost is right there.
Fair enough.
Yeah. So.
Makes sense.
Now,
I'm keeping my comments to a minimum. I won't get in trouble.
Yes, please, because you're going to get us all yelled at right now. And see, how many of these patients, they need vasopressors. Arterial pulmonary hypertension patients, when they crash, they need inotropes, they need pressors. It is a really bad crash. This is like basically milrinone, Voltaren, or something like that. They're the IV stuff, and and the inhaled is the nitric oxide. So there's a limit to the IV stuff. It works. It causes systemic vasodilation. And I need to be honest with you. If I'm going to put somebody on ECMO, I want to minimize using other drugs. You're already on mechanical support. Minimize using drugs to treat mechanical. Might as well go for the gold. Mm-hmm. And I'm a little biased. And I do not get paid from the nitric oxide company, I promise you. Okay. But I feel the key to life is pulmonary vasodilation. Now here, we put the patient on ECMO, this is what happened. And Joe's cheating, because I called him yesterday about this. So Joe, what's your thoughts here? Now you're
So differential hypoxemia.
Yes. So we put patient on ECMO. This is what happened.
Mm-hmm. And this is for pulmonary hypertension.
Yes.
In that,
what's your thoughts? What do you think we should do?
Well, if they have pulmonary hypertension, their LV is probably really not getting filled with much in the way of
absolutely
deoxygenated blood, because the flow is not going to be there. So and we don't know if the lungs are working or not, because it's just
we're gonna assume they're very minimally working.
Yeah. So in that particular case, I would probably advocate for cannulating the right subclavian artery and going VAA to make sure that I wasn't having that differential hypoxemia or Harlequin syndrome, whatever you call it. Or I'd stick a line if I thought that the blood was getting through the lungs, but just the lungs were not contributing. I'd put it in the right IJ and go VAV.
This is more common than
VAA.
People think in general lines.
It happens all the time.
It will happen many times where you will find out that you actually cannulate the patient. The patient is on VA ECMO and you have an incredible PO2s and you are very excited and very happy. And the next thing that you know, the pupils are fixed and dilated and there are no.
And somebody draws a PO2 from the right radial and it's 40.
Yep.
See, I've seen it. I can't tell you how many times.
And then this is the name that you guys. I don't know if you guys use the same name, Blue Man Syndrome.
Yep.
Yeah, for basically your half top, half is blue, and that's the importance. And I know we're here. Everybody on the web, I'm sure is very well educated on that. Right radial A line is mandatory. This is what the experience is. You have gotten this situation. People call you up. Oh, the PO2 is 400. Where did you draw it from? Up from the circuit, really? But the PO2 of the circuit is amazing. But that's not the patient's PO2. And that's, I think, what experience is.
Absolutely.
Experience is very important. Well, because if somebody calls you up and says, oh, Joe, the PO2 is 400, should you see the ECMO? Where did you get that PO2 from? So I'll tell you, this is very important for us here, like having experience. And this is just even where you're drawing your samples from, you know what I'm saying?
Yes. You have to, the right radial is probably it is the most accurate for determining what the brain is actually seen. Though
Absolutely.
you won't know necessarily the left carotid. The mixing cloud could be further, could be between the right, the innominate and the left carotid. We just don't know. But definitely it's probably what the coronaries are seeing as well. Although the mixing cloud could be just above the coronary, so you're preserving the brain, but the deoxygenated blood is all the heart is seeing, and it's never improving. So you really have to be able to think all the way down to just above that aortic valve.
Well, do you believe in cerebral oximetry?
Yeah,
Cerebral oximetry?
it is a technology that might be promising. I think that we need to learn a little bit more about it, and you know, the problem is still availability. You know, we need to actually get the entire team comfortable with the readings and understand what a false positive and a false negative is.
Yes.
I think that everybody's very comfortable looking at pulse ox when the pulse ox is 85, and you know that the patient is doing okay because everybody has a lot of experience with that. We need to have something similar.
Yes. And I don't think cerebral oximetry is a bad thing, but I think you have to, like you just said, recognize its limitations. There was an excellent paper written at one point called Pumpkin or Patient. And it showed where if I were to hook a cerebral oximetry up to your brain, Dr. Samir, right now, it would give me a reading between this range. If we killed you, it could still give you a reading between that range. And if we killed you and removed your brain, you would still get a reading. So if you put it on a pumpkin with a candle in it, you get a reading. The problem is, can you truly believe it? And so just because you put it on and it's giving you a reading that you think is good does not absolutely mean it's good. And
Was
that's
it-
something that bothers me. It concerns me.
Well, I'll tell you, the problem is you cannot take a reading, you have to take the trend.
Yes, that's true, but
That's it.
your
You have to
initial
look at the
reading,
trend.
but your initial reading has to be correct. So if you put it on, you have differential hypoxemia and don't know it. You put that on, and it says that that it's giving you 62 on both sides. Well, you're pretty excited, and then you're going to use that as your trend.
But you have to look at the whole
So
picture.
you're starting off with a bad number as a trend.
If you're blue, if you have a blue head syndrome, and you are 62, I mean,
then I
there's
don't
something-
need a cerebral oximetry to tell me that. I can look at the patient
But
and see
you're
if they
talking
look
about
like
you.
a Smurf.
We're talking about we have to have monitoring for the world out there.
Yeah, I don't have a blue hue. I'm more yellow.
I am not going to get there. Can we play that video, please? Yeah. So we just look at cannulation video, and we can talk about my little ideas about cannulation. I want to thank Tandem Live for supplying that video. So, I mean,
Did you do any disclaimers? Your Tandem Life isn't. They just gave you the video out of the kindness of their heart.
no,
Right?
but no,
We have to say that, you know.
Yeah, they are. I asked them for good animation videos, and they have an amazing video. Because again, not everybody is like you and amazing at knowing what ECMO cannulation is like. So, anyways, this is our regular VA ECMO cannulation in any like standard femoral any place. I now believe, and now Joe's gonna get so excited. You might have to control him. He might need ECMO right now.
Yeah.
Okay. So I believe that dual cannulation on top and bottom.
No ultrasound, first stick right in.
Again, this is the video. It costs a lot of money to do the video. Okay? So I told you you're going to have to control it. So I do believe cannulated from the neck, okay, also. And put the neck, instead of like not regular cannulation, put a Protect Duo. Something like a Protect Duo, which goes into the PA. And then you can cheat on that. So it's like a little RVAD and put an oxygenator. And that's you're oxygenating, and you try to overcome the pulmonary hypertension with a little nitric oxide. So that's like you have a nice pump facing against the wall, you know, pushing against the wall with pushing oxygenated blood, you know, putting the blood. The other idea, which Joe likes, which I'm not sure I'm comfortable with, and not every cardiac surgeon is able to do. He works with amazing surgeons. I'm not sure every surgeon can do a septostomy successfully, which needs a lot of echo guidance. We're going to do a septostomy. So, any comments, Joe?
On septostomy?
You're distracted with the video.
Yeah, I think.
okay.
No, I mean, I think doing a transeptal puncture for decompressing.
Can we go to the next video, please?
Left side is a good technique. So that's your standard VA ECMO.
Standard VA ECMO, exactly.
I would have chosen the other side for the venous only because it's got to go up farther, but that's...
See, I
Dr.
told
Zubieta,
you you're going to have to
too?
restrain him. I told you going to
The other video?
The other video, yes, please. We have to let the time the disclaimers go through. You know, we don't want to get in trouble. Is this talking from the?
I might not have to give my talk today. I'm going to run out of time. Dr. Samir, mine's okay. Okay, here now we're talking about. Okay, there's the heart stopped working. You got to narrate this.
So I believe this could be a very good strategy for pulmonary hypertension patients. You know, and you can get 2 in 1. Get an RVAT and an ECMO support at the same time. And when you want to start weaning, you can just put in a slice in and out the oxygenator. And it depends, what the strategy is for you in the institution. And I would be very honest here. Again, I might get beaten up outside. If your ECMO numbers are down or up, once you put the oxygenator, it becomes ECMO. You take the oxygenator, it's an MCS. And so really, I mean, it's a strategy a lot of institutions use. Because really it's just, you don't have to do anything with the cannulation. It's just the oxygenator in and out. We just don't have to run the whole video. Let's just get the neck part. So would you do a Protec and a septostomy? That's a little too much. I'm just putting on the spot. I'm just putting on the spot. I know.
No, I don't think so. I don't believe so.
Okay.
I don't know that I would do a Protec Duo for pulmonary hypertension. I can decompress the right side.
But usually the right sides of those patients are failing. The right sides are failing. They're dilated and totally failing.
But it doesn't matter because I'm going to be decompressing it with just VA ECMO. I mean, I'm going to be treating the
right
side.
But we're trying to get a look at the future. We want to put something with the future in mind.
Yeah.
That we can start. Patient can be the
Go ahead and speed this up a little bit. We don't need to watch the
come off
all this
ECMO.
fancy stuff.
Absolutely.
Forward,
come off
go
ECMO
forward.
and go to the right side support only.
Go a little. Okay, so there. That goes there. Okay. So now this is the Protec Duo you're saying?
No. This is
or standard venous.
No, we can go up a little more till we go to the neck.
Okay, that just looked like standard.
The standard venous, yeah, I think. Yeah, can.
Now this is.
Just actually accelerate it till you go to the neck.
And of course, and I'm not, while this is playing and they're doing all of this stuff.
So it's like a central line in the neck.
You have to remember that the problem with that oxygenator on the Tandem Life is that it has no heat exchanger. It was designed as a CO2 removal device, and its horsepower is inefficient for the size patients that we get and their metabolic demands. We can't oxygenate. You can't take somebody with a venous saturation of 50 or 45 and get their arterial sats up high enough because there's just not enough horsepower. Great for CO2 removal, not very good for oxygenation.
So anyway, the can goes into the PA again, so we really can push. But again, you still have to open the bridge, and that's why I feel there's a nitric oxide, like a swamp, pretty much. And you're just oxygenating and dumping the blood over there. And really, I mean, I think the only reason I like this strategy is for one reason. You can wean really actual central ECMO and have RVAD along, and then think of progressing from there. You know what I'm saying?
No, I think it's a good tool for right heart failure.
Absolutely.
I think it's also a good tool for just standard VV ECMO, although I think there are other ways to do that.
But those patients with the crash, as I told you, RVs dilated and failing.
Yes, but that could be secondary to left heart failure first.
No, it's secondary to lung.
If it's pulmonary hypertension, then of course that's just due to that.
Yeah.
I agree with you there. But again, the key is to decompress it. Once you've relieved the pressure, that goes away, and now so this is going to be drawing both. It's a dual lumen catheter, so you're draining from the right atrium, returning to the pulmonary artery under pressure.
And that's what I feel like, you're getting in one compact thing, one step, two things which are important.
Yeah, I don't think it's a bad tool. I just think that it's not a panacea like anything.
And no, there's nothing. You have to look what's good for the patient. I feel it's good for pulmonary hypertension because now they're young. You can get them walking with that at some point that you hope.
Yes.
That they can
Yes.
be. You can just like back in the Avalon days. You know what I'm saying?
Yes.
You can get them walking with that, and I feel it's starting to rehabilitate them.
Yes.
And those patients, because if you're going to list them for lung transplant, they have to be able to walk.
Yes, but and I know I'm going to get yelled at, but that's fine by those guys over there because I'm delaying things. But look, you have to make sure that you are making clear to people out there, our audience. You're talking about patients with a chronic illness that you're going to be exercising so that they remain conditioned for a transplant operation. If you're talking about a patient who is coming in with an acute disease or post-cardiotomy that we couldn't wean off bypass that took a right heart hit, or they have severe ARDS and developed pulmonary hypertension also and start having right heart failure, those patients are not going to be getting up and walking. These people are really, really, really sick. So it's these are two totally different patient populations that we're talking about, and I need to make sure the audience recognizes that you're not advocating this in the acute illness patient who is septic. They're not going to be getting up walking around with ECMO.
Just the pulmonary hypertension young population that we're getting them ready for lung transplant.
Agreed. In that case, I think it's a great device.
And here's the numbers prove what I'm saying. I try not to make up stuff. I try not to. So here's survival from ECLS to decannulation. You can look at the numbers and the odds ratio. ECLS was very important. Early implementation of ECLS was very important.
Agreed.
It's a young population that when you list them, they'll get along.
Well, the military knows that.
Yeah,
the golden hour. You
yes.
get the soldier from the battlefield
Exactly.
in his major injury to the hospital, their chances of survival are increased by incredible amounts.
The LAS scores will be high. You can be able to list them and get a lung for them.
Right. Time to balloon for the cath lab.
Exactly.
Time is muscle. These are all concepts I think all of us
So
understand.
that's really my point is ECLS them very early. Don't ponder too much. No journal clubs. And a lot of people are going to kill me on the way out. I get that,
No, we're not.
No, not you. The other two systems.
No, we're going to have your back because the thing is, I think everybody agrees, put them on. That's the easy part. Where we keep having the discussion, not in these patients obviously, but in the acute situation, is making the decision that, okay, we put them on, we've had an opportunity now to evaluate this. Yes, we should continue. No, we should not continue. That is the holy grail of decisions right there.
And if you look at in-hospital mortality compared to regular ECMO patients, compared to post-cardiotomy ECMO, they actually do better than post-cardiotomy. Reason is because there's a younger population. Mm-hmm. Most of them are a younger population, and their heart has not beaten up for a long bypass run. So, does that same comparison now really? But I'm trying to encourage ECLS is not a bad thing.
It's not the bypass run. It's inadequate myocardial preservation. Don't blame the pump.
So, but I'll tell you, ECLS does save. Do I want to put everybody on ECMO? No, but I do believe in ECLS.
He keeps asking me questions. I can't talk anymore. I'm done.
It's almost done, Magic, okay? I'm just going to look at the results and the conclusion here. They speak for themselves. Here, they want to recover them to the baseline functioning status, okay? They want those young population to go back to what they used to do before. If I recover from a disease, I want to be able to go hang out to the coffee shops like I enjoy now. I don't want to be hooked up to a machine and not able to do that. That's really my point, okay? And that's like, and extubate them, trach them and extubate, like decannulate them early. Like, don't leave them intubated and ponder the trach. Do you believe in early trach?
Yes.
Big time. Early trach them, and why not? There's a problem, you're hooked up again, you know what I'm saying? An early trach, I think, facilitates weaning, especially situations like that. You're going to walk around with ECMO, you decannulate it, there's a problem, we can always hook you up. I feel like making things simple, and I'm not that smart, sir, that's the problem. I try to make things simple for myself. Okay. Any comments, Joe, and with the end? Magic is all my fault, not his fault. I think the battery needs to be changed. Any comments about the results? And here is the golden statement. If I could say, the ECLS instituted by specialized multidisciplinary teams has a role in management of patient pulmonary hypertension, either as a bridge or non-bridge. But it's the specialized multidisciplinary team. That is the most important, the punchline here. And can, careful ECS cannulation, different configuration, whatever you choose, whatever you have a good experience with. And endotracheal intubation, I want to add to that trach, but I cannot change the paper. I would say endotracheal intubation and trach in dealing with these situations. Trach, intubate and trach right away. There's no need to wait 3, 4, 5, 7 days. Those patients intubate and trach the next day. Why are you going to wait for? It's not my fault now.
Next slide.
Yeah.
Next slide.
Yeah.
Next slide. Perfect. God, no, we don't have any questions. Okay, so let me. So how does the panel feel? Would everyone like to just go right into the next talk, or does anybody feel like they need a break? Feeling good? Feeling strong?
Yeah.
Okay, let's go right to Dr. Zubieta's presentation. And this presentation started off with us discussing this. And my talk is going to have sort of a little bit of a flavor to this. And I think you and I might have a good debate with this. Dr. Samir, I'm going to be interested to see what your perspective is, as well as Becky and Sharon. But it was going to be on common electrolyte disturbances in the ICU. Dr. Zubieta called to me up on the phone and he said, Joe, I'll be there all day. We have to narrow this down. So I'm going to focus on what apparently is the most prevalent of electrolyte disturbances, and that is sodium.
Well, yeah, it's true. We would have to spend the rest of the day, maybe the weekend,
The next weekend.
talking about electrolyte disturbances. So I told you, ain't gonna happen, dude. Then I decided that probably the best course of action would be to start with the first electrolyte. Just start with the sodium.
So we could do a series.
Maybe, if the feedback is actually positive and people like it, then we can talk about that. If not, well, at least it was only sodium and not all 4 or 5 of them.
Okay.
You know?
True.
It depends on the feedback. So I have no conflict of interest, and I have trouble with the control. Okay.
Oh yeah, can we fix these
I think it
slide
is
controller guys?
The objective is to understand the concept of osmolality, and tonicity. To talk a little bit about ADH, the complications that you might have with hyponatremia. We're going to start only with hyponatremia, and the treatment for hyponatremia. Next. Okay, so what is hyponatremia? Now it's working. So hyponatremia comes, if I can get to the next one.
Just say next slide and he'll switch
Next
it for
slide.
Just point, if you can point here.
you. No, I'm telling you, the battery's dead, dude.
Okay, so what is hyponatremia? So just so everybody's on the same page, hyponatremia is not a disease of sodium. Hyponatremia is a disease of water. That's the first thing that needs to be clarified. Next.
Here, let me have the controller. I'll fix it.
Okay, so the word hyponatremia comes from a Greek root that is hypo, that means that is below, a Latin word that means natrium, that is sodium, and emia, that is another Greek word that means that is a substance that is present in the blood. So hyponatremia will be a sodium that is low in the blood. It's as simple as that. Next. This cartoon is trying to actually show the different types of hyponatremia. So the height of the bar is the total water volume, and the shade will give you the concentration of the sodium. So on the first one you have on the left a normal, and on the right next to it you will have 3 different types of dehydration. You might have a dehydration in the first bar where the total water volume is less than normal, but your shade is very pale. That will be a hyponatremic dehydration. In the second one, you have a shade of red that is darker than normal, so that will be a hypernatremic dehydration. And on the last one, you can have also a isonatremic or normonatremic dehydration. There is another concept that you need to manage when you're talking about sodium, which is water intoxication. Water intoxication, the total water volume will be normal, but the concentration of sodium is low. And finally, in patients with heart failure, nephrotic syndrome, liver failure, you will have a total water content that is increased, and the sodium is diluted in that excess of water, and it will give you hyponatremic hypervolemia. Okay, so let's try to do it with a case. So a 23-year-old female presented to the emergency room with an acute change in mental status. The family admits that she has been taking ecstasy or MDMA for the past 2 or 3 days, and she went to a party, and the common knowledge in the street is that when you are doing MDMA, you have to drink a lot of water so you don't get dehydrated. So she's a good patient out of those street doctors, and she drank a lot of water in the party.
Would Gatorade have made a difference?
No, not much. So initial evaluation in the ER is giving us a sodium of 120. She does not have any alcohol in blood. She is negative for aspirin and negative for Tylenol. Okay, so the first concept when you deal with a patient with low or high sodium is the concept of osmolality. Okay, a solution is a homogeneous, this is taken out of the Webster dictionary, so this is not me. It's a homogeneous mixture of 2 or more substances that actually will be together until they get to a limit, and they have 2 components, a solute and a solvent. That solution will have several physical and chemical properties. The osmolality will be one of them. Other properties will be boiling point, freezing point, density, surface tension, specific gravity, ionization, pH, and the list keeps going and going and going. I just put some of them, okay? Now, some people say osmolarity, and some people say osmolality. Is that interchangeable or not? It's important to look at this slide, and we are talking about what is in the numerator and what is in the denominator. When we are talking about moles of solution, and you put it on the numerator, but in the denominator you use liter of solution, you are talking about molarity. But when you use as a denominator a kilogram of solvent, then you call it molality. If you are using the numerator instead of using moles, you're using osmoles, then when the denominator is a liter of solution, you will call osmolarity. And when you're using a kilogram of solvent, you call it osmolality. This is important, and I want you to remember this because I'm going to use the terms back and forth. When I'm referring to about solutions, I probably will talk about the osmolarity of the solution. When I'm talking about the patient, I will talk about the osmolality of the patient. So if you look at this substance, for example, and this is a U-tube, and this dotted line at the bottom is a semi-permeable membrane, you will see that this substance was able to cross the membranes and will distribute evenly all across. This substance A, that I'm going to call it substance A, is osmotically active, and it will move across the membrane without any problem. It has osmolarity, but it doesn't have any tonicity. That will be the term that we're going to start introducing right now. If I get another substance, that's what we were saying, is moving across. Let me try to move on. If you get a second substance, but this time the second substance will not be able to cross the semi-permeable membrane, it will stay only on the A side of the tube. That substance is osmotically active, and now is going to have some degree of tonicity, because the tonicity, what it does is that actually is going to pull the water and is going to create a difference in height in the water. And difference in height will be the tonic effect or the tonicity of the substance. Now, go back to the list of the physical properties of a solution. Tonicity will never be a physical property of the solution. How come? Well, just like height is relative. If you look at this cartoon and you see this guy A in the center, when you compare him to B, I is the little guy and B is the big guy. But if you take A and you compare him with C, you see that A is the big guy and C is the little guy. So how come A can be the big guy and the little guy at the same time? The reason is because you are saying taller or shorter when you are comparing it to somebody else. If I get this concept and I try to take this concept to a solution, then the solution A has some specific osmolarity, and when I compare it to the solution C that has a lower osmolarity, A will behave hypertonic. While if I compare A to B, B has higher osmolarity, so B will behave hypertonic to A, therefore A will be hypotonic compared to B. So now we go back to the same thing. A can be hypertonic or A can be hypotonic at the same time. Next. Maybe. Okay, so if we do the same thing, which and we call substance A normal saline, that has 308 milliosmoles per kilo. If you compare normal saline to some osmolality of 250, normal saline will behave hypertonic. But if you compare to a substance B that has 400 milliosmoles per kilo, it will behave hypotonic. Does it make any sense?
Yes.
All right.
Perfect. Good sense.
So how do we calculate this? So there is always a formula somewhere in some book. In this case, for our case, the sodium is 120, and the formula will be 2 times the sodium plus the glucose divided by 18 plus the BUN divided by 2.8. 2 times the sodium will be 2 times 120, 240. 120 divided by 18 will give you 8. If you don't believe me, just go ahead for your phones and check it, but believe me, it's 8. And 16 divided by 2.8 will give you about 2, so the osmolality of the patient will be around 250. When you are choosing the solution that you want to use for the patient, let's go back. Then the osmolality of the solution is 308 for normal saline that will behave hypertonic to the patient, and the osmolarity of the potassium that you're giving to replace the potassium, if you need to do that, it will be 700, so it will behave hypertonic also. Next. Let's switch a little bit and let's talk a little bit about ADH. ADH is the antidiuretic hormone. And the antidiuretic hormone is the hormone that controls the osmolality in plasma. Okay? Like any hormone, like thyroid or insulin, it is produced in one part of the body and it has its effect in another part of the body. In this case, ADH is produced in the brain and it acts on the kidneys. Too much.
Back one.
The job of the water is to save water. When the hormone is present, the kidney will save as much water as possible. Here is the thing. By default, the kidney will always waste water. By default. The only way that the kidney will not waste water, because that's difficult, it's like delivering good care. It requires an effort, it requires energy. So the only way that the kidney is actually going to make an effort is that they have a police looking over him. In this case, the police is going to be the ADH. It's going to make it do really concentrated. Next one. So this cartoon actually is showing us what happens. The osmolality will stimulate the brain, and the brain is going to release ADH to the kidney. The kidney is going to reabsorb some water and is going to produce some concentrated urine. I'm sorry, my animations are not as spectacular as yours.
Okay, they are amazing. They were not mine, sir. So yours are doing perfect.
These are very colorful.
These are homemade animations, so
they're
not
amazing.
As cool as yours.
Wait till you see my animations.
Yeah. So here it is. The first case, when the osmolality in the serum is high, the brain will sense that high osmolality. ADH will be released. The kidney will make concentrated urine, and the water will be absorbed, making the concentration or the osmolality of the plasma to go down. Next. What happens when there is no ADH or the ADH doesn't work? So the osmolality stimulates the brain, but the brain does not respond to that. There is no ADH, and the kidney actually pees out all the water that it can. It will produce large amount of water. Okay? In this case, when the osmolality is low, then the brain senses low osmolality, do not produce any ADH, the kidneys make diluted urine, water is wasted, and the concentration of the osmolality will go up. So this is normal. We're talking only about normal. And the way that we will remember this is, when your serum osmolality is low, your urine osmolality needs to be lower. When your serum osmolality is high, your urine osmolality needs to be higher. This is normal. Let's talk about a little bit of when it's not normal, because we're in the business of people who are not normal. If they are normal, they don't come to us. In SIADH, the serum osmolality is low. The brain will sense high osmolality. It will release ADH. The kidneys will make concentrated urine. The water is going to be saved and reabsorbed, and the osmolality is going to get worse. So that will be the pathophysiology, and I put in red the steps in the process that actually fail or are behaving abnormally. Okay? If you let this run, so you can always let it run. If you let it run, then you will run into the complications. And there are two types of complications of hyponatremia. The first one will be complications related to the water disturbance itself. That will be brain edema and pulmonary edema. And there will be complications related to the speed of correction. That will be CPM. Okay, let's talk about a little bit of the brain edema. So this cartoon Again, I'm sorry, yours is more impressive than mine. The dark shade on the left is the inside of the cell. The light shade is outside of the cell. The semi-permeable membrane is in between. The W's are water, and the red and light blue are the sodium. The system is in equilibrium because you see that the osmolality inside and outside is the same. So far, so good. What happens if the osmolality changes? Now the osmolality inside of the cell is 280 and outside is 100. And when the osmolality drops, the system is no longer in equilibrium. So what is going to happen is that molecules of water will start moving from the outside of the cell to the inside of the cell. And that process will continue over and over and over as the osmolality gradient exists between the inside and the outside of the cell. Once you reach a point where the osmolality inside of the cell is equal to the outside of the cell, then the flow stops. Back to equilibrium, yes, but all this water that came in actually increased the size of the cell. And if this happens in every single cell in the brain, and the brain is contained in the skull and the brain has nowhere to go, then what you have is an increase in the pressure. And you have an intracranial pressure syndrome, creating brain edema, herniation, probably death. Okay? How do we treat this hyponatremia? Well, I mean, the best way probably it will be the Adrogué-Madias formula. And if you look at the formula, this is the formula, and it looks a little bit fancy, but basically what it says is that the change in the sodium will be the change in the concentration of the sodium in the fluid that you're giving minus the concentration of the sodium in the plasma divided by the total body water plus 1. If I do it for normal saline, remember normal saline is 0.9% sodium chloride, and the sodium concentration is 154. So 154 minus 120, and we're going to make this patient a 58 kilo, 23-year-old female. About 50% of her body weight is water. So it will be 34 divided by 30. So that means that every liter of normal saline that I will give to this lady that weighs 58 kilos and has a sodium of 120 will raise the sodium by 1.13 milliequivalents. If I try to do the same thing with 3% hypertonic saline, somebody will come and say, oh, we need to give hypertonic saline because the sodium is low. Then the sodium concentration of the 3% is 513. And when we apply the formula, it gives us 393 divided by 30, and that will be 13.1, which means that if you give a liter of 3% saline, you will raise the sodium by 13.1 milliequivalents. Both formulas together. Now let's look at both pathways. Whether you want, we're trying to make the decision here whether we should give normal saline or we should give 3%.
You have to, I mean, it depends. I mean, if you're that low, a rapid change can create its own problems.
Exactly. So here we have both formulas, and the dose that we're going to give in a liter, the recommendation for 3% is about 100 cc's per hour bolus. It will be 0.1 liter versus a bolus of normal saline will be a liter, and that will change pretty much the same in either of the pathways. So what I want to say over here is that giving a bolus in these specific circumstances of 100 cc of 3% saline is exactly the same as giving a bolus of a liter of normal saline. If you continue and the recommendation is to raise the sodium by 5 points when the patient has seizures or he has a change in mental status, you should go up fast by 5 points and then stop there. You will have to give 4.5 liters of normal saline or 380 cc's of 3%, and it will take you between 4.5 or 3.8 hours to correct the sodium by 5 points. So the question is how much in a hurry you are. If it's really worth it, just the half an hour between 3.8 and 4.5, just to put the central line, to get an x-ray, to verify that the central line is in the right place, to talk to pharmacy, to get all the safety steps that need to be done on the 3%. Is it worth it or not when you can actually use something that is easier to give through a 18 gauge in the back of the hand or even in the antecubital. Now, the problem of being a theoretical person is that the formulas are just a guideline. So this is a very nice paper published by Stern where he actually looked at the correlation between the sodium correction that was expected by applying the formula versus the sodium correction that actually they saw on the patient. So if the patient corrects what the formula says that it was supposed to correct, you get 1. If the patient corrects less, you get less than 1. And if the patient corrects more, you get more than 1. Okay, and you can see that this graph is totally shift to the right, which means that the patients will always overcorrect. That it means that Dr. Adrogué and Dr. Madias were wrong. No, is that the formula does not take into consideration that we're talking about 3 different compartments. We're talking about the osmolarity of the fluid that we're giving, the osmolality of the serum, and the osmolality of the urine. Let's take a close look at the relationship between the osmolality of the fluid and the osmolality of the urine. So when is 0.9% saline not a good choice? So in this case, when you have 0.9% saline that has 308 and you give it to the patient, but the patient is not responding and expecting and is generating an osmolality of 800 milliosmoles per kilo, the urine is hypertonic compared to the saline. And what is going to happen is that normal saline is not going to be appropriate. Why? So here you have the normal saline. The normal saline goes to the kidney. Come on, cross in there. There you go. Okay. The kidney will actually generate, in the presence of ADH, it will generate a lot of concentrated urine. And the urine is going to be eliminated, and what is left is just pure water. And the pure water is going to go back into the system and make your sodium even worse. So when is normal saline not a good choice? If the solution's osmolality is less than the urine osmolality, so the solution is hypotonic, that's a bad idea. And the cutoff point is going to be 308. When the urine osmolality is more than 308, then you should not use normal saline on this patient. On the other hand, there will be a case where you are giving 308 of normal saline, but the kidney is producing 240 or 230 of osmolality. So now the normal saline is behaving hypertonic to the urine. And in that case, what is going to happen is that you give a liter of saline. Come on, you can do it. Cross, there you go. Okay, and the kidney is going to make diluted urine, which means that it's going to take some water, it's going to take some sodium, and it's going to leave enough sodium to actually make a correction that is going to go into the system. So when is the right treatment? It is the right treatment when the urine osmolality is less than 308 because it will behave hypertonic. Now you guys understand why I make so much effort trying to explain the big guy and the little guy and the hypertonic and the hypotonic in this case. Next. Okay, remember, any hypertonic solution, whether it's 0.9 or 3% or 2% or 5% or 23% saline, will be an acceptable choice as long as it behaves hypertonic to the urine.
There's 23% saline?
Yes, 23% is what now the guidelines use for emergency neurological life support when you have an acute emergency and your intracranial hypertension is going to kill your patient and you have to bring the pressure down. That's the right use.
Give like 50 cc's of it? Or?
Yeah, 20 cc's, 50 cc's.
Wow. I didn't even know that existed.
Depending on the protocol. Next. Okay, so in conclusion, the osmolality is a property that belongs to the solution, but the tonicity does not belong to the solution. The tonicity belongs to the relationship between the two of them. When the osmolality is low, one must use hypertonic solutions, and using the right way, any hypertonic solution will have the same effect. Urine electrolytes and urine osmolality is critical to the management of the patient. You just cannot do this, looking at the stars and looking at the position of the space station and what side of the moon is pointing at Houston or something like that. No, you actually need to measure, and you need to measure on a regular basis because this is going to be a dynamic target. Your osmolality is going to change as you actually do it.
Yeah, I'm so glad we're having this discussion because, we don't really spend a lot of time thinking about this. We know it, we remember it, but we don't really practice it. That's why you have to have intensivists in these critically ill patients.
That's why you have like 4 OR people and 1 poor intensivist here.
Yes.
Intimidated.
We were in the ICU too. That's where you know us from. We're always there with the ECMOs and stuff. We just are so focused on our little microcosm, our little silo. And this is so important, I think, for us to be thinking, that we're self-limited. This is critically important that we're hearing this because I've got my talk is going to, I think, really raise, you and I are going to get into a really intense discussion about this very topic that you just talked about. So let's proceed. I'm sorry.
All right, finally, aggressive treatment is not always the right treatment. All right?
Okay. What happened? That was it? That was your last slide?
I'm done.
Okay.
Okay, I have a couple of questions.
Yes, sir.
I agree with everything you're saying, but let me tell you some external factors which plays into that, like you said, multifactorial, plays into the formula. So fluid restriction, which is very controversial, is number 1. Do you believe in fluid restriction?
No. There are many treatments of hyponatremia.
What was the question?
The question was
does he believe in fluid restriction?
Restriction, okay.
Fluid restriction. There are many treatments for hyponatremia. We have fluid restriction. We have vasopressin, ADH, administration of ADH. We have administration of hypertonic saline, and we have Vaptans, tolvaptan, conivaptan.
And all that.
What we're talking here is the patient who is in the ICU critically ill, not the patient who is showing up on a doctor's office and the sodium is a little bit low. Mm-hmm. That would be a completely different management. I think that if you have a patient who is talking and is communicating and is able to eat and is able to be admitted to the floor and it will be safe in a 1-to-6 ratio, I think that fluid restriction, there's a role for that, especially if you have a hypervolemic
Then let me ask you, add more controversy. How about fluid restriction and sodium tablets?
Sodium tablets is part of the treatment, okay? Sodium tablets, in my mind, will be more indicated when you make the diagnosis of salt wasting disease versus hypernatremia. Giving sodium to somebody who is dehydrated because he has a bad case of cholera and he's having a stool that is hyponatremic. So if your stool is hyponatremic, you will become hypernatremic because you're losing more water than solute. So if you have a bad case of cholera and you try to treat it with a bag of potato chips and a salt tablet, that probably is not the best strategy. So, but if you have a total sodium deficit and you prove it and it's a salt wasting disease, then there is a role for sodium tablets. It's just that it cannot be one size fits all, and we're gonna everybody who comes over here with a sodium below 135, we're gonna give it a tablet of sodium, and everybody's gonna get better. I don't think that is that simple.
I agree with you, and I'll tell you, and not to make fun, but there's two places I deal with. One, and this is a reality. There also, it's an economic reality too for both of the places. One place will treat hyponatremia with sodium tablets, pickle water, potato chips, and fluid restriction, and the other one is covaptin, tolvaptan, or Vaptans. So
now, what are those medications? I'm not familiar with them.
The Vaptans are they're called aquaretic drugs,
yes.
and they call them actually aquaretic because they wanted to pretty much to keep him away from the cardiologist.
Okay,
Because
so they're
the
not
cardiologist-
diuretics.
No.
They decided, a decision was made
They
at the
are, but
highest
they're
level.
not. They are, but they don't call them that.
It's not a diuretic, it's an aquaretic. It makes you lose free water
Exactly.
Okay,
really fast. And the reason why
through
it
your
was not
kidneys.
classified, yes,
kind of like a diuretic does.
But it's free water,
Right.
It's free water.
not
no
salt.
pee.
Right.
Yes.
Right.
while Lasix will actually, you will lose
You're inhibiting
sodium.
the reabsorption of sodium and the lupus and all that stuff. So your water excretion is because you're losing sodium and the water goes along with it. Whereas with aquaretics, you're only losing water, not the electrolyte that it's dissolved in to go out.
Yes,
Okay.
close them up, yes. So there are many treatments.
How does it do that?
For hyponatremia.
How does it do that?
Well, I think that, again, how many hours do we have for this?
How does it do that? I just want to know how it does that. I mean, it's,
I'm the bad person now, Magic, not him.
There are two receptors that actually they deal with free water in the kidney, in the nephron, and it's this just like any other medication is an agonist or is an antagonist. Okay, and they go in there and they are highly effective. You can actually do a serious change in the water concentration, the osmolality of the patient with the aquaretics. But right now, there seems to be a consensus that there is no role for Vaptans in acute hyponatremia.
okay, and they're called
No role-
Vaptans.
Vaptans, V-A-P-T-A-N-A-N-S.
V-A-P-T-A-N, Vaptans. Yeah, I got it.
Even IV.
Tolvaptan is IV.
V, yeah. I mean, covaptin is PO. So.
I think that you will be seriously criticized if you try to manage an acute hyponatremia with Tolvaptan.
No, I'm sure, but
I'll tell you,
I just don't even know.
I'm
this
going to
drug.
have
Do
to
you?
say it depends on the institution, to be honest with you. I cover an institution where it's encouraged to take PO and ICU, move in and move out faster. It's just the reality of it. And you know, I worked in Memphis for a long time, and I know the realities of high-level critical care. But I have to tailor my critical care to the institution and the economic realities where I am. So that economic reality is where you are, dealing with the ICUs that encourages using PO quickly, so you get in and out. That's like using Entresto instead of Miranon. I mean, it's another example I'll give you. And from those examples, I can go over on and on and on. I mean, and there's some realities in the world. There's ICUs they cannot afford, you know what I'm saying, and they want to get the patient PO easy in, easy out, and get them on the floor quickly. So that's just the reality.
Okay, so My talk, I've changed it from what's on that card because that's going to be on December 10th. And it's going to be on CRRT, a topic that you and I have already had a brief discussion on. And I've got some pretty strong views about that. And in light of all of this that you talked about, I think it's going to be a very interesting, controversial, if you will, because I tend to like controversy. I don't know if you noticed that about me or not, but I do like it.
Really?
And I want to get the thoughts of Sharon, who has good experience with it. Becky, you have good experience with it. And talk about its involvement in not only the ECMO patient for a whole other variety of reasons, but also, getting out the evil humors and all these other, the bad juju, the gree-gree, whatever you want to call it.
The inflammatory.
But also inflammatory mediators.
That's what you meant,
forth,
with all
and
that.
And then also in fluid balance status and electrolyte disturbance correction. So I'm real interested to give my talk. It's going to be brief. My talk is very brief, and then have that discussion. But do you want to? We have to play our advertisements, I believe, because if not, they're going to kill. They've already apparently killed our air conditioner, so we have the windows open. So somebody didn't pay a bill. But do you want to go ahead and play the advertisements? And if anybody does need to use the restroom, but I just want to do the advertisements, go right into my talk, and limit the amount of break unless anybody just needs more time. And if everybody in the audience is happy with that, you guys can pause and then restart. So you have a little bit of an advantage. So you want to do that? We'll all take a quick break, run the advertisements, keep the lights on, and we'll just, how long does it take? How long do the ads take, David?
8 or 9
So we'll say 10 minutes.
Okay.
10 minutes. Everybody gets something to drink, and we have 10 minutes. And I'm just going to stay right here and get everything set.
And
we'll see you back in 10 minutes, okay? So only pause for 10 minutes.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP Venous Cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
Welcome back, everyone, to the program. So listen, before we go, I do my talk. Let's put the Slido up, make sure that they know where to go. And so you go to slido.com, you put in perfweb 30, where you'll see the hashtag. You don't actually put the hashtag, it'll have it on there already, perfweb 30. And then we're gonna have, I think there's 4 questions on there right now. Answer them, and then we'll show the results of the percentage of answers before we start the last discussion. But right now, we'll go ahead straight to my presentation if we can. Okay, so I think that the 2 previous talks from Dr. Samir and Dr. Zubieta were both very timely, and this presentation actually is designed to fit into both of those presentations, and let me go on and show you why. But what is the role of CRRT in the ICU patient? Because that's really the only place where it's truly appropriate. Well, what is wrong with CRRT, I think, is the question that I think needs to be answered, because I have a hard time understanding why it is not more universally used. Now, like anything, it's not appropriate in every circumstance, but in my view, CRRT is grossly underutilized in the intensive care unit, and especially with patients that are on ECMO. So it stands for Continuous Renal Replacement Therapy, CRRT. Therein lies the first and most significant problem with this therapeutic modality. Because what that does is it almost exclusively pushes it into the purview of nephrology. And you see here, it is mostly managed by nephrologists. However, there are some nephrologists, because their fellowships don't teach CRRT, or their fellowships actually taught that CRRT was not a good therapeutic modality for whatever reason, there are turf wars between intensivists and nephrologists. These are not really uncommon. I have seen places where ICUs, the CRRT in the ICU is managed exclusively by the intensive care medicine department, and nephrology had absolutely nothing to do with it. And I've been places where ICU medicine, for some reason, has nothing to do with it. They want everything to do with it, and they can't, because it has been shoehorned into the purview of nephrology. And I think this is a gross misconception of what CRRT is. So what's wrong with it is the name to start with. It should have never been called CRRT. Basic misunderstandings about the therapy are frequent, and thought that it is SLED, which is a type of dialysis done on a standard intermittent dialysis machine, which is slow, low efficiency dialysis. And a typical dialysis therapy lasts between 3 and 4 hours if the patient is stable enough. Sometimes it has to be aborted sooner, but SLED will last 8 to 10 hours, maybe as long as 12 hours. So again, the problem with that is, I'll ask Dr. Zubieta. Dr. Zubieta, how many hours a day does a kidney actually work?
When it's working?
When it's working, yes. When it is working.
24.
It's intended to work all day, every day. Right. The problem with these therapeutic modalities that are intermittent, even if you talk about SLED, is it's between 2, 3, 4, maybe as high as 8 to 10 hours. That is hardly what the kidney actually does. Non-renal, like CV surgeons and anesthesia, do, when you explain it to them, because a lot of these people are very busy, they're not interested. Dr. Samir, you're one of those people. You know, you do understand it because you have that mentality. Nephrologists, though some of them are brilliant people, I mean, as far as I'm concerned, but understanding the critical care patient in the ICU, on ECMO, multiple pressors, all of these things, not that nephrologists aren't smart, but they have a very narrow focus and not really looking at the milieu, if you will, of the patient and all of these other things that all are interacting with either the kidney or that the kidney is interacting with. Perfusion, we understand it really well, but some of them don't want anything to do with it because I don't want to do this. This is renal. This should be a dialysis nurse. This should be a dialysis tech, whatever they want to say. So I think all of these people who have this perception that they don't want to do something when it comes to this extracorporeal therapy that manages inflammatory mediator removal, manages fluid balance very precisely, manages electrolytes very precisely, removes metabolites very efficiently, corrects acid-base problems very efficiently. I think it's very misguided. Instead of calling it CRRT, it should have been called extracorporeal physiologic something machine. What's the word I'm looking for? I'm trying to find the word. I can't think of it right now. You got to help me out here. Stabilizer, normalizer. I don't care what you want to call it. Fluid, electrolyte, acid base, normalizer, and inflammatory mediator removal. Critically ill patients in the ICU. Well, what do we deal with all the time? We deal with the pressure. We deal with the cardiac output and cardiac index. Deal with perfusion. You know, the talk we're going to give on the 10th, and with this new microvascular camera tool that we have that we're going to look at, and you're going to help me with getting some good patient data for the folks in Amsterdam that sent me that device, is going to be very important. But it's very easy to have a good blood pressure, even a good cardiac output and cardiac index, and have horrible perfusion. You can even have what seems to be an inadequate blood pressure and inadequate cardiac output, you think, but the microvascular perfusion is really very good. I think one of the biggest things we do poorly and should do better is that we do not image enough in the ICU, whether that be even in bypass for the hearts. We don't do transcranial Doppler. We don't do microvascular circulation evaluation. We don't measure the arterial saturation in the appropriate points, especially when we are on VA ECMO and you're worried about differential hypoxemia. There's a lot of things that we don't do well, and we infer a lot of stuff from other things when we probably should be directly measuring it. That's what I believe. We deal with fluid management. We deal with acid-base derangements. We deal with electrolyte derangements and a multitude of other things, including multi-organ system failure or organ failure as a whole. So fluid is a big, big problem. Excess fluid is an even bigger problem. It's much easier to get it in than it is to get it out. There's no question about that in my view. When you have fluid overload, you develop cerebral edema, which causes impaired cognition and delirium. Myocardial edema, which means you get conduction disturbances, atrial fib, so forth, impaired contractility, diastolic dysfunction. Pulmonary edema, your lungs don't work as well, reduced compliance. Of course, if you're on the ventilator, you're going to have a higher risk of barotrauma, lower gas exchange, increased work of breathing. If the patient isn't intubated, they become tachypnic, and we see that they become exhausted, and then you have to intubate them in a hurry. And that I've seen patients. I have had a patient that was lying in the bed. He was maybe 3 days, 4 days post CABG surgery. He was just breathing really heavy, looked bad. And they wanted to intubate the patient. The surgeon told me, look at his x-ray. We looked at his x-ray. His heart was huge. His lungs were wet. The dude was clearly in pulmonary edema. We put a Maherker catheter in. I hooked a hemoconcentrator up to just a straight roller pump. I removed, I think, 6 liters of water off the patient over, 18 hours, 16, 18 hours. But within the first 2 hours of treatment, He was sleeping comfortably. I removed the first couple of liters in a hurry, and he immediately got better and improved. And it was convincing to me that this is a therapeutic modality we need to be using more of. You get renal interstitial edema. That causes, of course, a decrease in renal function. Hepatic congestion, we all know what happens there. Gut edema, big, huge problem because gut ischemia is a real big problem. And tissue edema. So these are all the things that happen when you get fluid overloaded. Survival is also grossly affected. In fact, there's a lot of work that's been done that shows fluid overload is an independent predictor of mortality. And you can see here that fluid overload of equal or greater than 10% has an appreciable, especially over time, appreciable increase in mortality. We've all seen this picture. That's what it looks like. You see her eyelids appear to be water balloons that you could grab and throw at somebody that you didn't like or wanted to mess with. But the hard fact is that when you see a patient that looks like that visually, and this is I can't remember who said this, a quote by somebody. I don't want to miss, I think it was Dr. Ronco, I think. But I want to make sure that I say, this wasn't my phrase, I stole it from somebody, I think it was him. Anasarca is not only a visually displeasing finding, because if that's what she looks on the outside, that's what her organs look like on the inside, and they're not going to work very well. You're going to have perfusion deficits, all kinds of problems are going to occur, and you're going to have organ dysfunction secondary to it. Acid base. When you have an acid base problem caused by lactate, it is a big problem. Now, notwithstanding, you have to solve the problem of the hyperlactatemia. You have to figure that out, okay, and fix it. You can't just clear it. But lactate on its own can create a lot of problems. In fact, you leave the lactate up high enough, long enough, you'll go into ARDS just secondary to hyperlactatemia. Is that correct? Dr. Z?
Not necessarily.
Not necessarily?
No. I mean,
you don't think so either?
Lactate is a marker, and one of the biggest mistakes that we're making these days is that we are labeling things. Now everybody who has a high lactic acid is in need for some specific interventions. That is not necessarily true. You have to remember the Cori cycle. And the Cori cycle is taking the lactic acid that is coming out of the glycolytic pathway back to the liver and convert it back into citrate. So patients with liver dysfunction, in general basis, will have what is called a type 2 lactic acidosis. Or it's not lactic acidosis, it's actually hyperlactatemia that the patient has, and it has nothing to do with microcirculatory perfusion or cellular hypoxia or cellular anoxia. It is very important at the beginning, especially when the numbers are high. You need to actually make sure that the high lactic acid that you are measuring is reflecting a state of low oxygen at the cellular level.
Yes, agreed with that it's an ischemic issue.
Okay.
That it's yes. So,
but the question was
but
whether
I was well. Here's what I was trained. Let me tell you that, and then you can give me that opinion. I was trained. If we have a trauma patient, and they have a very high lactate level, or you have somebody who has exercised themselves into a lactic acidosis, that if you do not clear that lactate, that lactate will lead to ARDS. Now, that's how I was trained.
No, that's not true.
The concept is wrong.
I agree.
what you need to actually do is that if the lactic acid does not clear, is because the insult is perpetrated over time. So the lactic acid is telling you, or an improvement in the lactic acid is telling you that your intervention, whatever you're doing, whether it's a liter of normal saline, or it's clamping a femoral artery that is pouring out blood, or is giving some red cells, or is using norepinephrine, whatever the intervention is working.
See, now I disagree with you, and I'll tell you why I disagree with you. If you have a gut ischemia and the lactate level comes back 5, and you pour in 2 or 3 liters of saline and you recheck your lactate and it's 3.8, that intervention hasn't helped at all. The ischemia is still there, the lactate's still being produced, but you have only managed to dilute it. Same thing with CRRT. You will mask a problem by clearing lactate efficiently. Dialysis would do the same thing. You clear the lactate, but you're still producing it.
I'm being quite a good boy, but I can't anymore.
That's all right, go ahead.
Okay, so you have an ischemic injury, like you have a dead gut, you can give 6,000 liters. You can give the whole Kroger water, you're not going to clear that lactate.
Well, if it's, okay, a dead gut, okay.
Well,
how about,
just said dead gut,
how about a portion? You have gut ischemia. I didn't say you have a whole
something that's dead. You have something that's
bowel.
dead in your belly. You can give as much food as you want.
We're talking about apples and elephants.
Exactly.
Yes, I know.
One thing is, there is no medical treatment for a surgical patient.
Correct.
Okay.
My point
So
is
if
you
you-
have to
Let me
correct
finish.
the problem.
Let me finish. If you have a dead gut, your bowel is dead, you need to get a surgeon who comes with a knife and get the bowel out, or the patient is dead.
Yes.
And the lactate will keep going up.
Surgical patients need surgeons.
Yes.
The medical management of the lactic acid of a patient who is having microcirculatory dysfunction is a different story.
Yes.
And that is actually, if we put it in that perspective, then I would say that there are 3 types of hyperlactatemia. The hyperlactatemia that is by regional hypoxia, because there is a dead leg, or there is a dead gut, or there is a dead liver, or there is a generalized hypoxemia at the cellular level, that is the lactic acid that we want to address, that we want to resuscitate in the first hour. And there will be what I call the type B, that is when the liver fails to convert the lactic acid into citrate, so put it back into the Krebs cycle. When you have a patient who is a candidate for a liver transplant and is on a waiting list and is status 1A, and this patient is having a high lactic acid, you can or you cannot give the fluids. The lactic acid is not going to clear because you need the liver to clear it, and it's not going to clear. Now, that elevated lactic acid is not telling you that you have to improve the microcirculatory perfusion. What it's telling you is that the liver is struggling. As a matter of fact, you will see liver transplant centers that use lactic acid as a marker of rejection in the acute post-transplant phase, in the first 6-12 hours. The patient comes from the OR already with a lactic acid measure, and we're going to measure it every hour. So we're not going to only look at how much bile the patient is making, we're going to look at how much lactic acid this patient is making, and we're going to look at the AST, the ALT, all those combined with the INR will actually tell us, okay, is the graft working or the graft is not working? But your question or your original statement is that the presence of lactic acid in blood will produce ARDS, and I think that there is no, right now, any evidence that is toxic. It's actually a bioproduct that is totally normal of the glycolytic pathway. Mm-hmm. So if it's normal, if a normal product of the glycolytic pathway, it could not be toxic. Now, what happened in ARDS with somebody with a dead bowel or somebody with a bad shock, What happened is that there are too many pro-inflammatory mediators that will attack the lung and will put the lung in a situation where the lung fails either from the hypercarbic point of view, or it will fail from the hypoxemic point of view, which is the most common one.
I'm gonna look this up, but that could be, I'm gonna look it up, but it could be that, of course, we weren't measuring inflammatory mediators back then. We didn't really fully understand them, and maybe there was an inference of this lactic acid increase is combined with these other factors. But don't look
it up. I'm telling you wrong. You know why? Because let me tell you, if that's your statement is correct,
somebody cut Dr. Samir's mic.
If your statement is correct, then at Memorial Park, where I'm setting up the tent for the Houston Marathon,
yes,
I should have vents for everybody. Because
no,
you're
you should have CRRT machines.
I know, we don't need that.
Okay,
we just take them to the hospital, resuscitate them slowly.
If you see on my slide here, I'll get back to my slides now. On my slides here, you will see that an elevated lactate over time, if not corrected through whatever means, for whatever the reason is, and this came out of the Egyptian journal. These are your folks, okay? Maybe Egyptian physiology is different.
Unless they're Houstonians, Houstonians are my folks.
Leaving lactate elevated alone is detrimental to survival in this particular study. So here are the common electrolytes we look at in the extracellular fluid, the column on the left, normally what we see. So what about CRRT? Well, CRRT is nothing more than really an umbrella term for an acronym soup, if you will. You have SCUF, CVVH, CVVHD, and CVVHDF. So SCUF is sustained continuous ultrafiltration. Its purpose is to remove fluid only. And that fluid that is removed is, to Dr. Zubieta's point, isotonic. If the sodium of the blood is 140, the sodium of the effluent that is removed will be 140. Potassium the same. It has no direct change to any electrolytes at all. It does not differentially affect any of the electrolyte concentrations. CVVH is continuous venous hemofiltration. This is used, and I'm going to talk a little bit about diffusive versus convective clearance here in a minute, but that is used for everything. Fluid management, it's used for electrolyte management, used for acid-base management, basically homeostasis of those things that are contained within the blood and blood plasma up to about 50,000 microns, or 50,000 Daltons, I'm sorry, in molecular weight. So it's very good for very small and very large. The pro-inflammatory mediators tend to be much larger molecules. I have CVVHD, and I have it crossed out because that is nothing but the same as SLED, and it is diffusive clearance only. It is pointless in my opinion, and I see it being done all of the time. But if you're going to do that, you may as well just do standard renal dialysis, intermittent dialysis. CVVHDF is, really when you're in a whole lot of trouble and you need maximum therapeutic volumes. So when you replace fluid, the CVVHDF gives you the opportunity to have every single one of the pumps running, and your, if you will, your effluent prescribed volume can be much, much, much higher than in any of the other therapies. So let's talk very quickly about clearance. There's diffusive clearance, which Dr. Z talked about. You have blood on one side, you have a solution on the other side with different concentration gradients. Things move across the membrane and go out in the waste. You can increase the amount of water removal as well, but having this dialysate basically gives you a concentration gradient. We're all very familiar with diffusion, so I don't want to spend a whole lot of time on it. Convective clearance is a little more complicated to understand. What that is a solute drag. And what that means is instead of a concentration gradient, you're now dealing with a pressure gradient. And the pressure on one side of a semi-permeable membrane is significantly higher than that on the other side. And there's a pump head, usually a roller pump head, in the area where you see on the left with the yellow on the top to waist, that is actually used more as a dam than as something that pulls anything across. So you want to control the volume being removed, and to do that, if you had it just free flowing, would be very difficult to do. So there's a pump that does that. And then you replace the volume, the plasma water removed, with a solution that looks like what you want the plasma water to look like. So if the blood, the sodium were 128, and you had a replacement solution of 140 or 144 or 150, whatever you wanted it to be, you can make it whatever you want. And depending on how great that concentration difference is and how fast you replace the solution, the plasma water, will affect how quickly you change the plasma sodium or to the level that you want it to be. And you can mix and match fluids, and I'll talk a little bit about that going forward. So here you take a look at a normal kidney, which is the orange line going off to the right, and that's what the kidney will remove size-wise in molecular weight. If you look at diffusive clearance, which is the green line, which is intermittent dialysis, it's really good up to about 6,000 Daltons, but you can see even at 40, at a clearance of only 40%, if something is under 5,000 Daltons in molecular weight, which are pretty small molecules. So diffusive clearance or concentration gradient clearance with a hemoconcentrator or a dialysis kidney is very, very, very weak. Anything larger, like an inflammatory mediator that may be living at 25,000 Daltons, is darn near impossible. In fact, it is impossible to remove with diffusive clearance in any setting. So the black line is convective therapy, and this is that solute drag I was talking about, where you remove large clumps of water under very high pressure, and it forces much larger molecules through the semi-porous membrane of the hemoconcentrator that's used. And this is very important. You have, let me go back. This is very important. If you have myoglobin, for example, convective clearance clears it very, very, very well, whereas diffusive clearance doesn't clear it at all. So here are the various fluids that can be purchased, and there's a whole bunch of others. This is just a few of them. But you can get sodiums of 140, 136, you can get potassiums of 0, 2, 4, 4, so you have a hyperkalemic patient, and you want to lower their potassium, and you want to do it faster than not. You can have two different bags up running at the same time, one of 4, one of 2, give you a 3, and run them both at the same speed. But you can do all kinds of things with this. If it's hyperkalemia, you can use 4. You can even add potassium to the bag if you want to and make it higher, or have the pharmacy do it. Calcium, you can maintain their calciums. If you use citrate protocol, then you wouldn't want to use calcium, but so they give you 0 calcium solutions if you want to do regional anticoagulation with citrate. Magnesium, chloride, lactate is 0, so if you have a elevated lactate for some reason, notwithstanding, I truly believe lactate on its own merit is detrimental. I am going to look this up. I'm going to get out my Guyton's physiology book. I am going to find it, and we're going to revisit this class. But nevertheless, if you want to get your lactate down, you have to have a solution that doesn't have lactate in it. And this doesn't, and you can get it down very quickly, but you can actually have solutions with lactate. I know they exist. Bicarbonate levels you can have at 35, 32, 25, whatever you may want. Glucose, of course, and the estimated osmolality is right there for you to see. Lower than sodium chloride, obviously has less sodium in it, but fairly normal, good normal physiologic solution. Now what's missing there is phosphate. When you do CRRT, you frequently end up with a hypophosphatemia, and you have to give some. However, new solutions being made now also contain phosphate. So they're trying to solve that problem as well. So what is the reason, my question, CRRT is not universally utilized and quickly, especially in the ECMO patient? Now, I'm going to say something else controversial. I believe every patient that goes on ECMO, except for the chronic patients who are getting transplant. I'm talking about acutely ill patients for either influenza-related ARDS, sepsis-related ARDS, whatever that reason may be, or VA ECMO for circulatory collapse, whether it be post-cardiotomy or whether it be they came into the emergency department and coded or had a PE on the floor, whatever those reasons are other than those chronic patients, I think every patient, as soon as they go on ECMO, should be hooked up to CRRT at a zero balance, very low therapeutic treatment, but having it available to very precisely manage their fluid status and to keep their acidemia down, keep their pH normalized, and keep their electrolytes normalized as well. You have to treat the albumin, though. If you're third spacing, that's a different issue. I realize it's a different discussion, but it's continuous. It's easily integrated into the ECMO circuit. It has a wider range of clearance to remove the juju, as I call it, or the evil humors, or the inflammatory mediators, or whatever term you want to use. It's a continuous fluid balance management system, and there is no need for an additional dialysis nurse. So I think that helps with cost management, because that's always a concern. But I also think that you manage the patient maintaining their homeostasis much more completely than giving diuretics and giving hypertonic saline or hypotonic saline or any of the other various different interventions we take. I think it gives your environment a much better opportunity to correct the other issues when all of these issues have been controlled. So that's my theory, or my belief. What say y'all? So let's go to the open discussion so I can get beat up now, because it's my turn. I see them. They're biting their tongues.
Oh, yeah, for sure.
So I'm going to start with Becky. No, don't start with Becky. I'm going to start with Sharon, because I need a break. You got to have my back, Sharon. Don't flip to the other side. Don't go to the dark side over there. Come on. What's your thoughts?
I like using it. I think it's good when we're on ECMO. It allows you the ability to take off water, dry out the lungs, and of course correct all your electrolytes. It's easy to hook up into our circuit, and it can be run by your ICU nurse. It's relatively easy.
And we can do it too.
Can you go back to the first slide of the talk, please?
Of my talk?
Yes,
Here, I
please.
can do that.
Please.
Here, I can do it myself. I'll do it. Here.
Yeah.
I'll do it. Here. I got it. You want me to put that lady back up?
No, the first slide.
Right there.
Okay, I'm going to have to ask you. I think critical care is a team sport, and I appreciate our nephrologist input, and I have no problem getting a nephrology assistance in the ICU or in the OR. We actually have
unless they're recalcitrant.
We have developed a protocol using CRT in the OR for transplant, LVADs, and no problem with that. Our nephrologists are very cooperative, but I'm not gonna say, I don't want to say anything. Perfusion is not much 100% cooperative with that situation. They want a nurse running that.
But it runs itself. You only have to change a bag now and again.
I'm just telling you the realities, sir. Okay. You asked me to give you the realities, right?
Yeah.
So perfusion is not 100% comfortable doing that. Okay. So we have to get the nurse for it.
I hear that a lot.
Yeah.
Can I, I don't mean to interrupt you, please forgive me, but I have to, because I'll forget. I hear that a lot. We're running a heart-lung machine where we have the patient's entire life in this little machine. We're giving cardioplasia to arrest the heart and provide myocardial protection so it can be clamped and all of its blood supply eliminated. We have suctions, we have vents, we're giving anesthesia gas, we're you know, we have the entire physiology of the patient at our disposal and all of their blood supply. And you're going to tell me, and this is what I hear it all the time, and it makes me angry. And you can't run a little CRRT machine? Come on.
I'm going to have to defer to the perfusion group, and you guys tell me why perfusion is not comfortable running it.
I think we're busy. You know, sometimes some cases, you know, you have to have a lot. You need more than 2 hands sometimes.
Yeah. In some cases,
Yeah.
in some cases, and I think in those cases, that's just a matter of we're busy. I can respect that, but if you're not really that busy and you just, well, I don't really understand this.
Sure.
Is that really appropriate, or is it your responsibility? Is it all of our responsibilities to learn it, to understand it, and to be able to be part of an overall global team?
But to her point is, those cases that need CRT, they are tough cases with a lot of blood transfusions, a lot of activity going on. Now, you're not going to do CRT on a standard cab. You know, there's a lot of activity going on if you need CRT. So there is
That's legitimate. You just need more help.
Yeah.
Have another perfusionist come in and help them.
So, and I'll tell you, running it in the OR, I don't think CV anesthesia loves CRT. CV surgery loves CRT. That's their thing right now. Lower the when the CV surgeon tell you, please put the CVP to 30. Have you ever heard it? No. Every every surgeon wants to lower the CVP. So, I mean, our CVP for our VADs is 15. Do not go above 15 regardless of anything. So we love CRT. And we don't want to correct electrolytes, so slow and easy is very good. And I'll tell you, our nephrologists, they are amazing. And I'm a little biased because some of them are friends and they help us in the OR, and I don't think there should be any problem running a CRT. And in the ICU, yes, if you're critically ill on ECMO, I don't think there's a role of continuous CRT for sure.
Or do you think every patient that gets put on ECMO in the ICU in an acute phase situation should have CRRT implemented soon thereafter, if not immediately thereafter?
Absolutely.
What do you think?
No.
No. I know. I knew that. I knew that was going to be your answer. That's why I asked the question. So, Dr. Z, you've been very patient sitting there, and you're bleeding from biting your tongue. The floor is yours, sir.
No, I mean, I do believe that there is a lot of science behind dialysis, that dialysis changed the world completely. But I believe that oversimplifying the problem is not a solution either. If the patient is managed accordingly to what we are preaching, that the patient should be aggressively cannulated, that we should improve the oxygenation aggressively, you should not lose the kidney. The kidney should continue to work, and the kidney will be a million times superior machine to any form of flavor of dialysis that you can implement. It's not unheard of that you can actually do a run of ECMO without having to deal with an acute kidney injury with acute tubular necrosis. Now, if you sit and you wait and you let your lactic acid go up, well, you know that the PO2 in the kidney is close to 10.
Very low.
The PO2 is 100 in the aorta. So it doesn't take a lot for the kidney to actually say, okay, excuse me, I need to go to the bathroom, you know? But at the same time, just dealing with this story, we have heard it before. Okay, so you have chronic kidney disease, stage 3, stage 4. We're going to do a CT contrast of the whatever, and we're going to put you on dialysis immediately. Those studies do not show absolutely any benefit. It will increase the cost dramatically, but it will not show benefit. I think that there is a role for continuous renal replacement therapy. I think that I have used continuous renal replacement therapy in different indications that you guys use on a regular basis. When I have an acidosis that is totally refractory, where I have a bicarb in single digit, and the patient is pressure dependent just because the pH of 6.8 or 6.7, or sometimes the machine comes back and says, I cannot calculate it because I was not trained to do that. Those people, you actually manage to get away by trying to do some form of renal replacement therapy with a high amount of bicarb without overloading the patient. That there is a role in there, but I don't think that actually draw a blank check that says everybody needs to be on CRRT, and we're going to actually from now on every single circuit is going to have a filter, and we're going to actually dialyze every single system. I don't think that that is the way to go.
Mm-hmm. And certainly I respect your opinion. I, however, respectfully also disagree with it. I think these people are so sick, and I'm just not, again, I'm not talking about the patient who was marginal that we put on ECMO very early. I'm talking about the patients who are really on ECMO because they're on they're sliding down they're on the slide, the big water slide that goes all the way down. And so I think it's a different phenomenon. I think that when you consider the invasiveness of ECMO in itself, and then you talk about adding a CRRT machine to the ECMO circuit with a very low effluent rates, or the fluid replacement rate very low, even if you're not using it for acid base, or you're not using it for some of these other things, there's a couple of things that I hear from people which cause me to take a step back and think, can that possibly be true? One of the biggest things is, I don't want to put them on CRRT because that's going to decrease the urine, the renal work. The kidney's going to stop working because you're on CRRT. And I would ask that person, how much blood flow does the kidney get? And the answer is all of it, right? It's going to get all of it. And it also consumes an enormous amount of energy. So it needs a lot of blood flow, as you said, with a good PO2. If I divert 200, 300 cc's per minute from my ECMO circuit back into my ECMO circuit, but don't change the amount of forward flow from the prescribed amount, cardiac output of 5 liters, and I turn that on, and I increase my flow to make sure that it's 5 liters here, but I'm taking 300 here, so it's not now 4,700, it's still 5 liters. How much less blood flow does the kidney see?
It's not about blood flow. It's not about blood flow. And I think that if you actually survey 100 perfusionists, the conclusion is going to be that less is better. The more tubing, the longer the tubing, the angrier the blood is going to get, the more pro-inflammatory agents that you're going to have, and that is what is actually killing the kidney.
And I think
it's not the perfusion itself.
But that same argument is, if we're on ECMO with all of that tubing, all of that oxygenator, all of that pump head, which is compared to a CRRT circuit, enormous. The CRRT, the added foreign surfaces added by a CRRT circuit is infinitesimal to an ECMO circuit, and the CRRT circuit actually has the capability of clearing inflammatory mediators, which on any patient on ECMO are going to be screaming.
I just don't believe that. I have a deep respect for the nephrologists, and I don't believe that the 3 years of the fellowship in nephrology is that oversimplified. I believe that the people who actually understand dialysis, understand the 4 modalities of dialysis, they will be able to actually implement the right modality of dialysis when it's appropriate and indicated. Mm-hmm. What I believe that you might actually be experiencing is that some of them are so smart, so intelligent, that they are not very good educators. They cannot convey the message. And we see that with very smart people. You have a very smart person who has a hard time dealing with interns, residents, medical students, because they have so much knowledge in there and they don't have the experience to actually try to make that a way they can be
That
easily
connection.
digested.
Is that
you
is
know?
that why everybody is having such a hard time understanding me today?
I don't know.
Apparently not. Rebecca, the answer is yes.
Sure.
Yeah, absolutely. Okay, so, well, with all of that said, I think that was a good controversial topic.
Yes.
We certainly are on opposite sides of the fence there, which is good. So let's go around the room. Oh, did we get any feedback on our Slido? Our questions? And believe me, I'm not saying I don't like nephrologists. If I came across that way, I love them. Dr. Kuo is like somebody who I have tremendous respect for. But listen, I don't know where you work, but I go places where nephrologists have said absolutely CRRT is the worst thing in the world and should never be used. And it's like everything. Nothing should always and nothing should never. You have to use everything in the appropriate setting for the appropriate reasons.
Absolutely.
And that's the bottom line. But I have dealt with that a few times. Did anything?
Yeah, give me a moment.
Okay. Watch if I ask him again, I could aggravate him. You got it yet? One person? Well, that's 100%. Who was that one person? Was it you?
No.
That's pretty weak. I would have probably rather you told me no. 2 people. Does the second question pertain to ECMO only? Either way, I am unsure as I am new at my institution. I have an exit strategy. That was for ECMO. Do you have an exit strategy for ECMO? And somebody doesn't have it, okay. 2 people said they do have an ethics committee. No, they
Nobody.
don't.
Yeah.
Okay, well, just 2 people.
Wow.
Do you perform ECMO? 2 people, okay. Yes and no, so 50-50. Yeah, there's a lot of places. That's good. Yeah, I'd rather you just told me nobody said anything. There were 2. That was painful. Thank you. Anything else you can do to help me today? So anyway, all right, you can cut that. Yeah, take that away. Get rid of that. Put something else on there. But anyway, so with that said, let's go around the room. Any final thoughts? Becky, you are first this time, whether you like it or not.
Okay. As far as like CRRT goes?
Anything about this whole program, about everything we discussed. Any final thoughts on all of this?
No, I thought that each one of the presentations were very well thought of, and all the key points were met. I do have a question about like the antidiuretic hormone and seeing that in patients like with do you deal with patients that are on bypass like post-operatively or ECMO patients as far as kidney function post-operatively? Sorry, that didn't come across very clearly.
That's okay. You want to try again? Like, what's your question?
Just antidiuretic hormone being like, I guess, monitored for our ECMO patients.
So do you monitor ADH?
We don't.
Does anybody? I don't know.
I don't think so.
Yeah, I don't
I
know.
don't think so because by just looking at the osmolality of the urine, you know what
You
the
know what
ADH
it
is
is,
doing.
so you can infer it from
So
that.
you get the osmolality of the patient, you get the osmolality of the urine, and
Yeah.
you know what the ADH is doing.
Sure.
Okay. There is an SIADH that is nephrogenic. You can give a little bit of ADH, and if it's nephrogenic, the kidney is not going to respond. If it's central, the kidney is going to respond to that. But this having some kind of an acute SIADH, I don't think that is something that we see very often. You can actually talk to a lawyer and you can come with that theory that SIADH can happen acutely out of the blue and the emergency room physician will be responsible. That would be short as stupid.
Yes.
But SIADH requires a kidney that is not working correctly for a period of time. If things get out of control and you have brain edema and you are at risk of herniation, is when the emergency neurological life support guidelines will kick in. We are right now trying to disseminate the guidelines from the Neurocritical Care Society. But you have to intervene. There's no argument about that. And the treatment is not salt tablets. The treatment is not the microcycline. The treatment is not BDAVP. The treatment is not steroids. The treatment is not water restriction. The treatment is hypertonic saline.
But you know, you didn't talk about this, and I had mentioned about sudden correction of the sodium and demyelination syndrome.
Well,
so you know, because we
get
have to be
into
careful
that.
about that.
I didn't want to get into that, but here is the problem that you have when you correct sodium really fast, which is what you are trying to suggest with dialysis.
No. Don't time out. Wait, Doc. No, well, I'm not going to let you squeeze that one in. No. The beauty of CRRT is that you can correct it slowly over time and not have to give the patient fluids if the patient can't tolerate fluids at the time. So that's not fair, but go ahead.
Okay. So what is my line of thought?
You were talking about demyelination, sudden
The
rapid
problem,
increase in
yes,
sodium.
The problem with correcting the sodium too fast is that the patient is going to get better like this. And everybody's going to be happy because the damage to the brain is going to happen on day 3, on day 4. Usually the patient is out of the ICU already. And now you have a patient who is not waking up. The patient was having seizures. The patient was having a change in mental status, was comatose. There is no argument. There is no argument that it was an emergency. There is no argument that we had to intervene. But if the correction is too aggressive, well, you see that your patient gets better immediately. And the surgeon is going to be happy, or the intensivist is going to be happy. The family is going to be ecstatic about it. Okay? But 3 days later is when you're going to see the damage. The patient is going to fall into a coma and is not going to wake up. And that is the problem. And usually the person who did the dramatic, radical correction of the sodium is not the person that is going to see the patient 3 days later. So this person is blind to the consequences of the action. And if you look at the literature on hyponatremia, what you see is that it took years and years and years of documentation for us to learn that we should not actually correct the sodium. And we have come down dramatically. From the time that I was in med school, we corrected 20 points, to right now, if we are correcting more than 8 points in 24 hours, we should be screaming and panicking, and all the red lights should be on, and all the warnings should be there. We should be giving drugs to slow the correction of the sodium. Making things worse, because of the formulas that we have, they tend to underestimate the correction. On top of that, you have patients that are called overcorrectors, that even if you actually do everything by the book, they will correct dramatically. And those people are at risk of having CPM. They will get better in the ICU. They will be transferred out of the ICU. They will be on the floor the day that they fall asleep and they never wake up.
That's scary. Is there a threshold on that? In other words, you know, you see a sodium of 132 and you want to correct it to 138 versus a sodium of 122 or 120, and you try to correct that to 138. Is there a threshold?
That is a great question. In general, if you ask people, we'll tell you, oh, sodium is greater than 120, we don't have a problem. Yes, we do. So we started with sodiums less than 100, they were dangerous. Then we say sodiums 110 were dangerous, 120s are dangerous. Now we're talking about 125 is actually a risk for the patient, and it should be taken seriously. I would not refuse an ICU admission on a patient with a sodium of 129 if the patient is symptomatic. I will bring him to the ICU, I will do the entire exercise, and I will correct the sodium slowly. Now, if the patient is an acute emergency, that is when the patient has seizures or when the patient is comatose, then the recommendation right now is to raise the sodium fast in 1 or 2 hours, raise it 5 points, and then you stop. And the next 23 hours, you're going to raise only 3 points for a total of 8 points in any 24-hour period.
Mm-hmm.
That's why I'm telling you that dialyzing a patient with hyponatremia or hypernatremia is actually tricky. And I will leave it for the geniuses who actually went to the nephrology fellowship and leave me in my fellowship of critical care when I don't need to be that smart to manage my machines.
Fair enough. Fair enough. So, in fairness, Rebecca, is this your first time on camera?
It is.
Has it been? What kind of? Has it been a good experience
It's
for
a
you?
good experience.
Mm-hmm. Mm-hmm. You dropped your mic. It's always fun to do things for the first time. Exactly.
Yeah, it is.
Well, it's been. I've really enjoyed having you here. I know
you.
that it's hard when it's your very first time,
Yeah.
but you can't see anybody.
No, I know.
That's the beauty of it all.
Something
But you know,
just know they're looking. You know.
yeah, maybe.
Yeah.
We only had 2 people answer Slido, and I think it was our staff. Okay, so Dr. Samir, how would you like to close this out?
I'd like to just about pulmonary hypertension or any ECMO patients. Please, no journal clubs. Do the right thing very quickly, very early, and get ethics involved very early and be honest with the families.
Mm-hmm. And I'm so glad you brought that up because I agree with you. Oh, sorry. I agree with you 150%. You don't have time to sit and hand wring and contemplate whether or not to put the patient on ECMO. You got to do it if you're not, or don't do it, one or the other.
Exactly.
And you do. But that's the big problem is the exit strategy.
You need a plan of
You
action.
really have to have it. So if you were counseling or consulting with a hospital that was going to open an ECMO program, start an ECMO program, because that's becoming very popular right now, what would be your 3 pieces of key advice to them?
Multidisciplinary team from everybody, perfusion, critical care, CV surgery, cardiology, pulmonary. Nursing for sure. And pharmacy, okay, because our management for drugs. And I'll tell them an ethics person, a strong ethics program. And if you make a decision, patient needs ECMO, you have to have a criteria for who you're going to put on ECMO. You decide you're going to do it. Mm-hmm. And then meet with the family immediately after. Mm-hmm. Tell them this is what we did, these are our expectations. And you have to update the family continuously and show them what the trend is happening and be honest with them. Mm-hmm. And be true to your numbers. I mean, the numbers that critical care came up with about how many organs lead to the outcome is going to be bad. If you have a 3-organ mortality is very high.
Very.
3-organ failure, the mortality is very high. And actually, I believe in the 20-20 number. If you have a total belly of 20, you're not going to survive. Mm-hmm. Lactate of 20, you're not going to survive.
20 is very high.
Yeah, so you're not.
There are some pairs that we like for example, things that should never happen. Like your hemoglobin and your INR should never be the same.
No, that's a bad sign too.
Exactly.
Exactly.
And I'll tell you, I mean, those 2, people make fun of those numbers. The numbers really, they're true and they're good, projection. 2020, then you just be honest with the family. Nobody gets mad about being honest. And that's what I encourage the hospital to do. And have in place a system how these patients are going to be taken care of from staffing point of view, from perfusion and nursing, and how critical care is going to cover those patients.
Excellent points. I'm going to ask you 2 gentlemen to select choice A, choice B, or choice C. Choice A is a perfusion-only ECMO program where perfusion does the initiations with whomever the cannulator is, stays with the patient in the ICU for the entire duration of the ECMO run, is there for the removal of the ECMO, and goes on their way. Choice B is a completely nurse-run program where nursing goes in with the cannulator and does the initiation. They stay with the patient in the ICU through the duration till the decannulation. Choice 3, or B, or C, choice C, is a blended program where perfusion and nursing work together. The perfusion comes in for the initial cannulation and stabilization. Once stabilized, the nurse takes over and manages the patient through the duration of their ECMO run. If they feel like they need any assistance or a circuit change or rounds being done, The perfusionist would come in and check it, be available by phone. You would also have an intensivist monitoring the patient via, actually that's going to be choice D. Choice C is everything I just mentioned. The nurse manages the decannulation, but it's a blended program. And then choice D is that blended program with the addition of an intensivist who can call up on his phone and see, or his iPad or his computer, the patient, see the room, see the ECMO, see the flows, see the pressures, see all of the hemodynamic monitoring, review the labs and everything else, should there be the need for a medical intervention of some sort. A, B, C, or D, which would you choose?
You are asking somebody who actually was blessed with the experience of having to put together an ECMO program. And what we did was to take a group of RTs and a group of nurses that were motivated, and we made them ECMO specialists. With, for lack of a better term, that was the term that we were using.
It's a good term.
The ECMO specialists, and they were actually, with the training and with the experience, they were very good. And we trained them in emergencies, and they were able to actually change an oxygenator on a time that was compatible with a perfusionist. Okay, they were things that I was very impressed with in the program was the degree of detail-oriented way of looking at that. They were getting the flashlight and they were tracking the entire tubing system with the flashlight, looking for little pieces of fibrin that were accumulating. They were reporting to us in regular basis. This is happening. This is how it's happening. Look at the oxygenator here. Look at the oxygenator there. It was an incredible experience. I think.
Do you mind if I ask where that was?
Scott and White.
Scott and White. Okay. Yes.
So if the objective is to have the perfusionist in there at the beginning, because it's an intimidating thing, especially when there is a lot of blood on the floor. Once you get your ECMO specialist to a level of proficiency that is acceptable, then your perfusionist can be actually diverted to go to the OR, to be available on call, to be available in the house first, available on call second, and then you actually transfer the program in there because it's more efficient.
I just realized that I met you at Scott and White because I went there and did some locums ECMO coverage when you guys were training your RTs, and I did some RT training while I was there.
And it was
the beginning time of it. That's where I first met you. I now remember that.
Yeah, and we did with transport, and there were levels. When you start with transport from one bed to another. We started transporting a dummy from one bed to another. Then we actually did a formal training where we were able to put the patient on the elevator safely, get into the CAT scan and get him out of the CAT scan,
Yes.
put him on the elevator and bring it. That was a level. And the next level, by the time that I left, we were talking about using one of our satellite hospitals, going, cannulate the dummy over there, put it safely in an ambulance, coordinate with the paramedics, with EMS, transport the patient safely to our ICU, get on the trauma bay, get the patient on the elevator, and get him safely into the ICU. There were specific roles and procedures, safety procedures, that we were actually teaching them, and when they are very motivated, they actually do an excellent job.
That is, those are all, that is I love what you just got through saying. So you do know that we are in the process of opening up a nurse ECMO specialist school. I'm not going to call it nurse ECMO specialist. ECMO specialist school, because RTs are welcomed, if you will, here in Houston. It'll be the only one that is, the next closest one is 800 miles away. And I think that what works for one place May not work for another, may not work for another. But I do respect very much your opinion about this, and I agree with you 100%. A really good nurse is, as far as I'm concerned, just as capable as a perfusionist if they're trained properly, because they understand a lot of what's going on with the patient already. They're not starting from square one. So I think one hospital may want a blended program, and that works for them. One hospital may want just nurses, and that works for them. One may want RTs and nurses because that works for them. And it really depends on volume and exposure and where your support is. If they're within close proximity, perfusion, for example, it's a lot easier to have a almost exclusively nurse-run program. If they're farther away, then it's less desirable to have that because you don't have that support. But very good points, and I hope you will help us with that education process. But I also think there's places in the country that don't really have intensivists in-house. They have an ECMO patient. You've got to monitor that patient. There's not a perfusionist within 200 miles. You can have an intensivist like yourselves, and since Dr. Samir, you're so into telemedicine, that can actually be monitoring that patient, see trends occurring, tell them what to do from a medical management, but also you need to call somebody in because you're going to need some help doing this, changing it or whatever it may be. What do you say to that?
I say we all have to learn from other people doing things, and we don't have to reinvent the wheel. So Colombia piloted a program where they're doing monitoring of their ECMOs internally. They put chips in the ECMOs that are transmitting information to a mainframe. And it's working perfectly for them, but that's an internal program, just for Colombia. So I do see systems and small hospitals that are interested in putting ECMO, like we talked about, and they want to have expertise. And you don't have to have the chips in the equipment. You can have a camera. We can look at the platform, see what's going on. And from the data, you have to be linked to the EMR, see what's going on with your gases, what's going on with anticoagulation, what's going on with the lactate and things like we talked about. So I think having that available can be part of tele-ICU, which people are not seeing. I think MCS right now, on all levels, should be part of tele-ICU, a dedicated part with people with special expertise. And I hope the technology can be responding that some of the companies can insert chips in their equipment that can transmit the data to your computer. And that really was going to be amazing, if that happens,
I think telemedicine is clearly, and it's still in its nascent stages, but it is going to have to become a normal thing because there's perfusionists, people aren't going into this field. Physicians, there's a lot less people that want to be physicians these days.
And people thought telemedicine is going to be for smaller hospitals. It's actually not. Bigger institutions right now are using it for their whole system.
Yes.
Yeah.
Yes, absolutely. That's another very good point. But we certainly have a shortage of medical professionals.
Yeah.
I don't think there's any question about it. And I don't see it getting better anytime soon. So, you're last.
Okay. What percentage of awake ECMO do you do?
Awake as in
upper body cannulation,
or
ambulating and physical therapy?
Well, ambulating after they're cannulated. Cannulating awake, we're doing almost zero. Okay, that I'll tell you, be honest with you.
Okay.
But early extubation, ambulation, we have an amazing, and Joe knows, an amazing physical therapist.
Yes.
We ambulate patients on ECMO 100%, like if you can ambulate. But like if you don't have a femoral strategy of cannulation, so it's if you have a neck strategy, whatever the cannula going to use, it's going to be with a ProTac, Duo, Avalon, whatever it is. And everybody thought disasters were going to happen and the things patients are going to spew blood into the sky. That has not happened. Right. It has happened with patients laying in bed, nobody watching them.
Oh, yeah.
Yeah. So I'll tell you the ambulation, and I think not everybody can be ambulated. Yes, he's right. But if you have a young person that you want to get stronger, that you're going to give them a transplant, and you want to maintain that transplant, you need to get them stronger.
Yes.
Right.
Yeah.
Well, you don't want to let them decondition.
No.
That's really it's maybe not necessarily getting stronger, it's keeping them from deconditioning by becoming immobile while they wait in the bed for 30 days to get their transplant. That's really, I think, the issue. It's prevention of deconditioning more so than necessarily
I mean, you have no, how many of these patients are so nutritionally impaired that they get the skin breakdown, the cubitus, and now you start thinking, oh, you're an ECMO or you're an MCS, and you have to do a diverticulostomy to avoid that. I mean, that's it. It's over at this point. And it's all because you did not really get out of bed and you ambulate and all that. So, I mean, I'll tell you, I believe in getting out of bed is the cure of all evil, but you have to choose your patient.
Yes, you do. And I think that is the takeaway message from that is that people hear things, oh, they're getting their ECMO patients up in chairs. Okay, but we're not talking about this kind of patient that you just got. This patient got a white count of 25,000. They're really, really sick. They have an acute inflammatory process of their lungs. They're in heart failure now too. They're in acute renal failure, acute kidney injury. I don't think they're
Plus,
getting up.
we've got to respect age. Age will always be on your side.
Yes.
Younger you are, I mean, definitely going to be on your side. We have to respect, it's the state of life, you know what I'm saying?
Yes.
So
Yes.
if you have like a 25-year-old is different than a 65, different than a 90-year-old.
Yes.
I don't care what people say, it's a 90-year-old, she's so active. She walks around every day, so what? She's 90 years old. She has a 90-year-old body.
Yeah.
90-year-old protoplasm, you know what I'm saying?
Is she going to be able to
Yeah,
recover from it?
exactly.
Right. Is she gonna?
Yeah.
Right. What's her meaning? What is the chances of her having?
Meaningful recovery.
Right. I mean, right. Exactly. That's the big problem.
Exactly.
The big question. Okay. We'll see you all. We're right on time. We will see that right on time. We will see you all December 10th for our program. We're gonna have Mark Tatum here from AngioVac. There's also going to be, I don't remember the name of the physician he said who uses AngioVac a lot, is going to be Skyping in on that program. We're going to have a demonstration of what I was supposed to do today on that bench right there, and it's going to be super cool with a model. I'm going to show you how you can put a patient on VA ECMO from an acute saddle block PE, and then using the single circuit go into the pulmonary artery, vacuum out the unwanted intravascular material, clear the obstruction, and remain on ECMO and slowly try to wean if you can. If not, keep the patient on VA ECMO with a single circuit. That's going to be a really cool, and I've designed it right here in that kitchen. Okay, so it's going to be pretty interesting to see this.
That's interesting. It's in the kitchen.
I haven't
Not the
tried
garage,
it.
the kitchen.
I haven't tried it yet. Well, look, I wanted to do it in the kitchen so I could have some snacks. In the garage, you can't eat. Okay, and then we're also going to have Dr. Mathura from Amsterdam with the microvascular camera is going to do a lecture on that for us, and I'm going to also, hopefully, Dr. Zubieta, you'll be able to join us and talk about some of the patients you actually used it on, and we can see some of the benefits that you may feel about that device. And then we're going to have a couple of just discussions about some perfusion-related topics on. So it's a 4-day program next on December 10th, 11th, 12th, and 13th. The 10th and 11th will be great. The 12th and the 13th are just fun. I'm not sure they'll be very educationally useful, but they'll be fun, and you get credits for them, so that's all that matters, right? Okay, see you all December 10th. Send your questions. If you have questions for Dr. Zubieta, for Becky, for Dr. Samir, for Sharon, for me, email them to me. I'll make sure they get distributed. And thanks very much. Adios.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking? hotel, and meals out, this totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.